My name is Francesca Bodwin. I'm the interim dean in the School of Public Health at Brown. And so on behalf of the school and the university, welcome. Thank you for attending the summit on the future of health policy in Rhode Island. And I'm particularly delighted that we have so many state legislators who are planning on attending our event today. In addition to Speaker Shekarchi, I'd like to recognize Representative Susan Donovan, Representative Brandon Potter, Representative Marianne Shallcross-Smith, Representative Teresa Tanzi, Senator Lou DePalma, Senator Elena DiMario, Senator Victoria Gu, Senator Megan Kallman, Senator Pam Loria, Senator Linda Ujifusa, Senator Lori Urso, and Senator Bridget Valverde. Thank you all so much for coming today. I also want to thank and acknowledge the Brown 2026 initiative. On the 250th anniversary of our nation, Brown 2026 is focused on the role that research and teaching universities have in sustaining democratic societies. In a healthy democracy, lawmakers are accountable for evidence-based policymaking, which can drive improvements in access and quality healthcare, as well as improving our public health systems. Today's summit is exactly on this larger objective and is a demonstration of how academic researchers can support policymakers as they tackle the key issues right here in our state. This is fabulous turnout, especially given I know many of you battled the roads this morning. In this room, we have policymakers, researchers, healthcare leaders, advocates, journalists, members of our community. And I think this is a testament to the importance of the topics that our panels are going to unpack today. And I also hope it's a demonstration of the shared optimism that we can address these problems together. I was reminded this weekend of Brown's motto, in Deo Speramus, in God we hope. And hope is also the motto of Rhode Island. And I've been thinking a lot about hope lately, and I think we all have a lot of hopes and dreams for healthcare in this country. But hope is not this like magically things we'll all just wish and magically things will happen. Hope is what happens when good people show up to do the work and solve these problems together. I can't think of something, quite honestly, that's more Rhode Island and more Brown. When there's a challenge, there's always people ready to step up. I think our panelists are part of those people, but so are all of you in this room. There are parts of talking about healthcare that are difficult and complex, but I can't think of something that is more relevant to the moment we're in. Obviously, I'm biased as Dean of the School of Public Health, but it is also something that impacts each one of us, whether you're caring for an aging parent, you are a parent, or you yourself are navigating the healthcare system. Sometimes we talk in terms of budgets, regulations, systems, but it's really all about the people and the families whose lives are impacted, and I know that's why we're all here. Today's panels are going to cover 3 of the most pressing issues facing our neighbors, our friends, our families: access to primary care, affordability, and how we in Rhode Island are going to navigate forthcoming Medicaid cuts. Throughout the day, you're going to hear from leaders across government, academia, and the healthcare sector who are deeply involved in these issues. You'll also learn about the Rhode Island Life Index. This is something I'm particularly proud of. It's a long-term collaboration between Blue Cross Blue Shield of Rhode Island and the Brown University School of Public Health. And it's meant to understand the quality of life and well-being in our state. Our hope today is that we create a space where we can have productive, informed conversations about how the state can strengthen its healthcare system and help the people in Rhode Island live healthier, happier lives. But here's a thing, and I guess it's a good thing: good conversations are only the starting point. Where we need to go from here is translating this evidence into policy action and practice. At the Brown School of Public Health, I do want to give a shout out to today's host, the Center for Advancing Health Policy Through Research, or CAPER. We always love a good acronym. It plays a central role in that mission. here at Brown, but also in our state. At both the federal and state level here in Rhode Island and across the nation, they're working directly, every day practically, with policymakers to move the needle. Over the past year alone, they have engaged numerous different state legislatures from Vermont all the way to Oregon. And you will see a number of these researchers on our panels today. I'm really excited for you to hear from them. And I want to call out a few people specifically. The center's director, Andy Ryan. Andy and his leadership have really helped double down the efforts of CAPER to do health policy work here in our state. And Andy helped bring on Nathan Hostert, who many of you know because Nathan did yeoman's work in organizing today's event. But more importantly, he is leading the center's engagement with state policymakers. And finally, I want to thank Ateev Mehrotra, our chair of the Department of Health Policy Services in Practice. I got that wrong, Ateev, Health Services Policy and Practice, and a member of the Brown 2026 Steering Committee. He was really the spark for this summit. And this event, this whole event, would not exist without partnership and our commitment to the communities we serve. And in particular, I want to acknowledge the leadership and vision of our next speaker. So with that, it is my great pleasure to welcome Christina Paxson, President of Brown University. Thank you, Chris.
Thank you, Francesca, and good morning, everybody. It's great to be here, and it's just my honor to welcome you to this summit. And we're going to be talking about the future of health policy in Rhode Island and how to get better care for everybody in this state at hopefully more affordable prices. I want to recognize everybody here in the School of Public Health. These things take a lot to put together. The Center for Advancing Health Policy through research has been seminal. Francesca thanked other people. But again, thank you. And it's wonderful to have events that bring together community leaders, legislative leaders, Brown researchers to talk about really important issues. Francesca thanked all of the state legislative leaders who are here. So I'm not going to go through the list again. But I just wanted to underscore, having the speaker here, having so many of you here, it means a lot because you're at the front lines of grappling with the challenges that we're going to be discussing. And I know there's some hard decisions that have to be made. So thank you for making them and treating them with such, seriousness and in the best interest of the state. It's much appreciated. It's no secret that healthcare matters to Brown. And almost 60% of the doctors in the state are affiliated with Brown's Warren Alpert Medical School, so we have a big footprint here. Every time I go to the doctor, I love seeing the Brown logo on people's shirts. And the partnerships with Brown University Health and Care New England and the Providence VA and others has been really central in training the next generation of physicians in the state through residency programs and things like that. I think you also know that we're heavily invested in the jewelry district. Here we are. And this was Brown's first actually, after building the medical school, which is in an old jewelry factory, this renovation, which was a partnership between the state and the university and private investors, was our second big foray into the jewelry district. And if you look out the window, I don't know if you can see it, Danoff Life Sciences Laboratory is going up. So this area of Providence has become really important, sort of a connector between the healthcare systems and the university. We employ thousands of people, and they use healthcare. And so as an employer, this is something that really matters to Brown as well. So the investments are there. I'm an economist. Some of you know that I am a health economist. And over the course of my career, my research, and I speak about it in past tense, sadly, I don't really have time to do it anymore, but my research focused on the intersections of economics, healthcare, human well-being, poverty, and inequality. So this is something that I'm really excited about. And sadly, I can only stay until 10:30, but at least I'll get a little bit of the first panel, and that's important to me. A few other comments. Our academic mission is to serve the community, the nation, and the world through research and education. And it's that service piece that I really want to emphasize today. And it's through research and education. You're going to hear about great research that informs policy and practice and have discussions about what's actually feasible, what actually might work. I think that's important. Brown School of Public Health is really at the center of this kind of translational research. And, you know, so many of our researchers, so many of our scholars are connected to organizations in the community, and they're really thinking about how what they're learning, what they're studying, how the students they're training can contribute to make the world better, make health outcomes better, make stronger healthcare systems. Now, it was already mentioned that this is part of our Brown 2026 initiative. And this is the recognition of the 250th anniversary of the founding of our country. And you might think that this is all about, you know, colonial times and what happened 250 years ago and what Rhode Island's role was. And it is about that. The leader of this initiative is a professor named Karen Wolf. She directs the John Carter Brown Library, which is an amazing library that has the history of the Americas up to 1825. But as the steering committee for that initiative got together, they said, hey, you know, we care about the past, but we care about the future. And we know that universities play an important role in sustaining strong democracies and supporting the democratic process. And so a decision was made, and actually the steering committee was expanded, and luckily we got public health in there, to think really about important, critical, immediate issues that this country is facing that are of deep concern to anybody in a democratic society, or should be of deep concern to anybody in a democratic society. So that's why this is part of Brown 2026. Let me say a few words about the panel, especially focusing on the primary care panel this morning, which is something I'm really interested in. And, you know, I'm not here to advocate for any specific policy or solution. This is what you all, the panelists, the legislators, are going to figure out, and something our expert panelists are going to discuss. I do think that this is a really tricky time. You know, we know that state budgets are stretched really thin. We know that a Medicaid cut is coming. We know that the state has many other demands on its resources, and all of this makes it complicated. We also know that people are having a really hard time finding primary care, and it should be the foundation of a really strong healthcare system. So the questions that I would like to know more about is, you know, do we have the reimbursement rates that we need to attract and retain top quality primary care physicians? How do we bring these newly minted physicians, whether they're trained here in Rhode Island or educated, do their residencies in other states or here, how do we bring them here and how do we anchor them in the state? I love this state. I expect everybody in this state does. You only need to spend 3 or 4 years here and you're anchored. So how do we create the anchors? I think we need a primary care anchor program. That's the only recommendation I will make. I don't know what goes into it. And, you know, how do we think about providing primary care more efficiently? Do we need to make better use of electronic medical records? Do we have the system we need? How do expert nurse practitioners fit into this, and nursing in general? And again, nursing is a really important issue, and if we focus only on doctors and we forget about nurses and all of the other paraprofessionals who support the healthcare system, I think we're probably missing something. So these are really complicated issues. The policy solutions, some of them are more immediate, some of them are much longer term, so we're thinking what investments do we want to make today for things that are going to help the state in the future. So my hope is that the discussion this morning can clarify the answers to some of those questions and get us all thinking about it so that we can make really good decisions for the future of the state. Before I close, I have to recognize that it was not long ago, not many weeks ago, that Brown experienced an unimaginable tragedy. And we've seen a tremendous outpouring of support from Providence and Rhode Island since December 13th. From the first responders in Rhode Island who got our students to Rhode Island Hospital. The health care they received there was amazing. And again, from doctors, nurses, social workers, you name it. And even local community members who pitched in. We had students who were sheltering in stores, in restaurants, in private homes. Families were pulling them off the street saying, come in here, right, and be here during the lockdown. I want to recognize some of our really important partners in the state and local government. Margaret Holland McDuff, is Margaret here? There you are, you're right there. Family service at Rhode Island was phenomenal, so thank you. And also the PPD, not PPSD, the Providence Police Department, the support we received in a wide number of dimensions was important. So last point, just maybe to underscore some of this, I hope all of you think of Brown School of Public Health, but also the Watson School of International and Public Affairs, the medical school, faculty across the university. I hope you think of us as partners and resources and places where you can go if you want to get information about really pressing issues that are facing the state. Just one plug, we have a vice president for community engagement. Her name is MJ Callan. And we set that up sort of as the one single entry point. I've heard from a lot of people, I want to get help from somebody at Brown. Who do I call, right? It's not easy. And the answer is contact MJ Callan, right? And she will make sure that you get connected to the right resources in the university. We want to have it single point of entry, single door, and then we can be more effective at what we do. So thank you all for coming, and I hope you enjoyed the summit. Thanks.
Well, thank you all. There we go. All right. Well, welcome, everybody. Thank you so much. Let me make sure everyone can grab their seats there. Perch ourselves up here. My name is Ateev Mehrotra. I'm a physician and a professor at the Brown School of Public Health, and I'm excited to be the moderator for our first panel, which is going to focus on primary care. As has already been alluded, it's a critical issue. When you go around the state, what do you hear all the time? In coffee houses, restaurants, why is it so gosh darn hard to get a primary care doctor around here? And you see it in the headlines, imminent collapse, crisis. We hear and talk a lot about this. So the goal of this panel is to try to give all of us a better understanding of what underlies this, and what do we do as a state to try to address it. And I can't think of a better set of panelists to try to discuss this issue. So let me quickly introduce them. First, here on my right, is Joseph Shekarchi, who's the Speaker of the Rhode Island House of Representatives. And the Speaker has led so many efforts in the state to try to address this crisis. I'm really excited to hear his work, what's motivated that, and what's to come from there. Next, we have Martha Wofford. Martha is the President and CEO of Blue Cross Blue Shield of Rhode Island. This is something she has to address on a daily basis in terms of her members and how they struggle with this issue. Next, we have Caroline Richardson, who's the chair of the Department of Family Medicine at the Warren Alpert School of Medicine at Brown University. And Caroline addresses this also just as a primary care doc, taking care of patients, but also as a researcher and as an educator, training the next generation of primary care clinicians. And it's going to be really important to get her perspective on that. And last but not least is Jason Buxbaum, who is a professor at the Brown School of Public Health, has been doing a lot of really interesting work diving into the Rhode Island system and some of the challenges that our residents are facing. So let me start the questions here. What we'll do is I'll have a number of questions, and at the end, we'll try to leave 15 minutes or so for all of your questions. So keep those questions in check, and we'll have you stand up and to answer those. So I'll start with the speaker. You go nationally, people think of Rhode Island as the leader in this space, having done so many innovative work. I wonder if you can give us a little background on what have been the efforts to improve primary care in the state and what motivated them.
Thank you. It's a pleasure to be here, and I'm happy to share this panel with some distinguished people, and I appreciate the opportunity. So let me first say that everyone likes to call the speaker and look up to, but I just lead a group of very talented 75 individuals who really work very hard. Some of them are here today. I want to recognize them. Start with our chairwoman, Susan Donovan, who chairs our HHS committee, one of the vice chairs, Brandon Potter, Teresa Tanzi, and everything I do regarding healthcare goes through my healthcare policy expert, and that's Lynn Urbani, who's here as well, and she's the best. So what we've done, I get a lot of credit for, but it's just the whole team, and it's really people. I stop for a minute with nothing to do with healthcare, which is housing, and people say, you know, you're pretty much leading the housing effort. How come? I say, well, I didn't choose housing. Housing chose me when I first became speaker. In the last 2 years, I didn't choose healthcare, but healthcare chose me or chose the House. We're at a crisis level here in Rhode Island, and it's not unusual. I'm on 2 national panels with speakers from around the country, and other speakers, other states are facing the same crisis. Healthcare is a ever-changing landscape, and unfortunately not for the best. But we have done some amazing things in the last couple of years. We're going to continue to. With the help of my colleagues in the General Assembly, we put over $40 million more into healthcare reimbursement for primary care. With the help, I believe it was Brandon Potter's bill, we got rid of prior authorization, which was a big problem for many doctors who would complain about having to spend an hour or 2 every day filling out forms for tests and procedures and drugs that they know that they were going to authorize that they needed to be done. So we try to eliminate the red tape to make their life easier. They're going through burnout. I spent 2 years, my primary care doctor retired. She's younger than I am. She was burnt out, and she moved to California. She was done and got out of the medical business. And I had 2 years without a primary care doctor. I have an excellent doctor right now. I'm very, very happy with him. I'm not going to say his name because I don't want everybody else to use him. So, but he is unbelievable, and I feel very comfortable. You get a certain connection with your doctor, and it's wonderful. But beyond that, we've done a lot of things beside the money end of it, the money aspect, and prioritize it. A couple of years ago, she's not here today, but I know Teresa Tanzi was a big help with this, but Rebecca Kislak led an effort to pass the SHIELD law, which protected doctors from treating their patients without the fear of being sued, either civilly or criminally charged for giving health care. My dad was a doctor. He's 99 years old. He turns 100 in 2 weeks. And I have such a, thank you. And he's got his health challenges, as most 99-year-olds do. But I will tell you that I have so much respect for the medical profession and what they do. And the one thing I learned from my father was no government, nobody should ever get between, no drug company, no bureaucracy, between a patient and a doctor. And when I looked at, when the SHIELD law was presented to us, it was this all-encompassing thing. And it was, you know, people said, the SHIELD law. And when you look at it, it's like 80 pages long. And there was like criminal aspects of it, and there was civil aspects of it. And our team, a great team of lawyers and policy experts who worked hard on that bill 2 years ago to make sure we have one of the best SHIELD laws in the country. Doctors were, when Roe v. Wade was overturned, some states were prosecuting doctors who were giving advice through Zoom or over the internet to other patients, and they were trying to charge them and bring them in there. And it was ridiculous. So we wanted to lead that effort, and we did that. We're studying the possibility, and I encourage everybody in this room, including especially Brown University, who I've spoke to a couple of their deans and professors, of looking at a medical school down at URI, or maybe somewhere else. But we need to do something to create more doctors, especially primary care doctors in Rhode Island. And we're going to continue that effort, whatever it is. But we're going to have very public hearings. We're very transparent in the House, and we welcome input from everybody.
One other, if you could just,
Sure,
before I turn to the other panelists, one of the things that a lot of people talk about Rhode Island is also our primary care spending goals, which are really pushing the envelope here, focused on spending 10% of our dollars, our healthcare dollars, on primary care. Really innovative idea. Curious what your thoughts are about that. I'm not sure your involvement in that.
Well, we listen to David Cicilline, when he took over the Rhode Island Foundation, commissioned a study to look at why our reimbursement rates are so low when our premium dollars are relatively comparable with Massachusetts. Why are we paying so much less for our doctors? And the truth is, we in Rhode Island cover so many more things than they do in other states. And there's a cost to that. And I know Blue Cross will speak in 1 minute, and they'll tell you that we cover so many things in Rhode Island that they don't cover everywhere else, and there's only so much dollars. We can continue to raise health insurance, and that will price ourselves right out of the market so people stop getting health insurance. You know, the last point I will tell you is, it's, as everyone in this room knows, it's an ever-changing landscape. What happens in Washington has a direct impact on what happens in Rhode Island. Whether it's the SNAP program, whether it's health insurance through our exchange, whether it's right care, we can go down the list, but things are changing, reimbursements are changing, eligibility is changing, everything is changing, and unfortunately for us in a state, it's not good. There is a little ray of hope here, we did receive $156 million under the Rural Health Grant. We are still unpacking it, waiting for guidance on what we can spend it on and what we need to. And it's not a secret, but yesterday, with my colleagues in the House and the Senate, cooperatively working together, and we don't always do that, with the governor's office and the Attorney General. It hasn't been easy, but since the month of September, we passed an $18 million rescue plan to keep those 2 community hospitals afloat. Is it the best plan? Is it a good plan? No, it's not. I see Lynn Blaze there. I know you're happy about it because you're 2,300 workers work there. We want to protect those people as well. But it's about primary care, and then it's about the workers. But we did that because it was the best solution we had in front of us at the moment. Could I think of a much better opportunity, lots of other things? They didn't materialize it. We have a solicitation period that's open right now. And I will tell you, as of yesterday, no other healthcare agency or entity or hospital system has expressed any interest. So we passed some legislation. The governor will sign it this afternoon. And then we'll continue, and hopefully they'll be able to sell the bonds immediately and close by the end of the month. And if they don't, then the alternative is going to cost the state far worse. You're talking about primary cares, but we need to look at the whole continuum of care, whether it's nursing homes, whether it's staffing, across the board, specialty medicine, all of it seems to be in crisis at the moment. And our hospitals, we need to continue to support them. And we have. We have as a state, when we had our COVID money, when things were good, we were getting appropriations, we spent a tremendous amount of money on healthcare. We want to continue to do that. Whether it's the Rhode Island Free Clinic, which we gave $1 million, whether it's Open Door Health, which we also gave $1 million. These are community-based organizations. We passed the 340B program to help people. I can go down the list of the initiatives, but all of these take money, and we have a limited supply in Rhode Island, and it's an ever asking request for funds, for allocations from the state. And the first question is, did you go see the governor? Are you in the governor's budget? Sometimes they say yes, and then we want more. Sometimes they say no, and that means we have to either do 2 things, both are not popular, cut somebody else's funding, or raise taxes. Yeah. So.
Well, thank you very much. You know what I thought I might do is just, I'm going to skip, we'll come back to both Caroline and Martha in a second here, but go to Jason here, and you've done a lot of really important work understanding and characterizing the primary care problem from the perspective of patients. Maybe you can level set for the audience here in terms of the numbers we have in terms of primary care supply, and also access, and what are Rhode Islanders experiencing?
Sure thing. Thank you, Ateev. I was hoping you'd ask. No, but so to drill down on primary care in particular within the broader landscape that the speaker was discussing, I can offer a few figures, but first a couple disclaimers. If you'll let me, the data quality in this area is bizarrely bad and shockingly bad. And to the extent that we have good insights, a lot of it comes from Caroline's team. And I'll get into a bit more of the limitations of what exists in a moment. And I also just wanted to emphasize that I think when some of the figures I present, it's not to say that things are good here. I think it's to say that things are challenging everywhere. Perhaps not everywhere, but in a whole bunch of geographies. So to give you some particulars, according to a Kaiser Family Foundation commissioned analysis of state licensure records, we have 2,500 PCPs. That's not anybody's experience here. There's no way that this figure accurately represents what's going on. I think gets at a whole bunch of measurement difficulties, particular how you count internists, with a whole bunch of, with a substantial share, a majority of internists practicing in the subspecialties. So that limits some visibility if you were to just kind of take these raw counts. Others will say that we're in a relatively strong position. The AAMC suggests, that's the American Association of Medical Colleges. Thank you, I nailed it. Would suggest we're third in the nation for primary care capacity, like third best. I don't think anybody here would be content with where we are or say that this resonates with our experiences, but these are what you get when you kind of look at a 50-state landscape. Another measure you can take relates to just asking folks about their access individually, and one of the best sources here is the BRFSS, the Behavioral Risk Factor Surveillance System. It's a multi-state or 51-state survey. And one of the questions on there is, do you have a personal doctor? And we actually come in fifth or sixth best in the country. I don't think that's to say that things are great. I think it also speaks to kind of some of the nuance here. Perhaps if you have a doctor already, your access is fine, especially if you have the speaker's doctor or retired doctor. I guess the new one sounds all right. Was my sense.
You might be hit up with a lot of people asking you who that doctor is.
Yeah. But I think these figures can't really give us insight into just how challenging it is for the 11% or the balance of folks who are looking. And so I guess the one other thoughts I wanted to just reemphasize here is just how hard the measurement issue is. And I want to just commend Caroline's team on some of their work, because you can take these counts, but you don't account for necessarily for the fact that primary care providers are overwhelmingly not practicing 100% primary care. I think that was one of the big learnings from some of your team's research, is that you have to minimum divide by 2 to kind of take account of physicians, APRNs, PAs, and get to a figure for primary care. So I hope looking ahead, maybe this is easy for a researcher to say, that we can get more and better information here, because it's really hard to get a good pulse.
Well, thanks, Jason. So I want to turn to, and it's good to have that level setting. So Martha, I wanted to turn to you, have you go into a little bit more depth about Blue Cross Blue Shield of Rhode Island's efforts to improve primary care. And I wonder if you could touch upon the reimbursement issue in particular. It comes up all the time where Rhode Island clinicians are paid less. What do you think we're getting right with that question and wrong? And give us your thoughts on that in particular.
Yes, absolutely. And first of all, I just want to say thank you for having me here, and thanks to Chris and Francesca, and thank you to the speaker for your leadership, particularly on housing and on primary care. It's been really impactful, and to the whole legislature. At Blue Cross, we're really focused on how do we improve sustainability of primary care, and rates is a piece of this, for sure. It's a big piece. And so I'm sitting here looking at the insurance commissioner last year, OHIC, passed a rule, as you referenced earlier, that led us to increase primary care rates. And that was for fully insured commercial. So that's one of the lines of business, has a lot of the population in the state. And so at this point, year over year, we have increased those rates 50%, which is a tremendous amount. But the reality is the Medicaid rates are abysmally low. And so it is not enough for practices. We are trying to make up for the shortfalls on the state funding on the backs of employers, and it is really burdensome. So again, it's some progress, but it's only one portion of a provider's panel. The other thing, we have to make sure that those dollars actually go to the primary care physicians. There's a lot of people in between the payments that we make and then what actually gets into a PCP's pocket. So that's another area to look at. We've also done a lot on innovative payment models, and so we've invested over $500 million over the past 10 years outside of rates to try to support practice transformation. And what's happened in the last couple of years, as there have been very high medical costs, is that the value-based care arrangements that we had actually caused providers to lose money. And so they've stepped back from those arrangements for very good reasons. And so what we've done is come up with different models, particularly something called PCP capitation, which pays pays physicians prospectively each month for their patient panel. And this is intended to give them more sustainability, and I think is meeting them where they are on risk. It's also helping them open up their patient panels to take on more patients because they're incented. They're paid more for each individual patient they take on. In some cases, that's made access for existing patients, to your comment earlier, somewhat harder. I know for me, I actually had my annual physical turned into my 18-month physical. So we're in a little bit of a balancing act of how to do that well. The third area has been reducing administrative burden. So last year, Blue Cross voluntarily in April reduced prior authorizations for 65% of medical prior auths for primary care. And later, the Office of Health Insurance Commissioner, per the bill that we referenced, then went to 100%. So, and I will talk a little bit later about the difference there because I think it's really important if we have time. But I wanted to just, before we do that, I want to just step back for a minute because I think these steps are good, but they are not enough. And I have tremendous empathy for how hard it is to be a primary care provider here in Rhode Island and across the country. It is all of the charting that is taking place, the prior authorization, the referrals, there's a tremendous number of forms that have to get filled out. There's reimbursement pressure, there's medical malpractice, there's all kinds of things that make it a really, really hard job to do. And I had the privilege of working in primary care in other markets where it works much better than it does here. So where there's actually been practice transformation to move to team-based care. And so I'd love to talk about that later if we have time, because I just think there's another way to practice that can actually reduce burnout really significantly, which is a huge, to the speaker's physician's example, is a huge driver of some of the challenges. So that's just a big piece I have energy around. And then I just think the structural challenges that we're facing right now with incredibly high healthcare costs, which is driving premiums to be very high. And I think we have to be incredibly careful with the structural challenges of our population where we have one of the lowest percentages of commercially insured people in the state. And so those low Medicaid rates have a disproportionate impact. And that is why you saw Anchor go out of business earlier, because they had a higher percentage of their patients were Medicaid patients, and they couldn't make the math work. So we have to figure out, we can't just say, let's have commercial rates go higher and higher, because then employers drop coverage, I think, to what you said, Mr. Speaker. So there's a lot that we need to do structurally, I would point to.
Yeah. Martha, you raised some really critical points, and I wanted now to turn to Caroline to give us the frontline perspective. And maybe I just highlight both what's driving the primary care crisis, and one thing I would love for you if you could touch upon is the state has done some initiatives, increasing Medicaid rates recently. It's early. Medicare is pouring money in through primary care through the APCD money that's APCM money that's coming through. We're also seeing a demand that a certain amount of spend is on primary care. So on some numbers out there, it looks like more dollars are going to primary care. Give us the frontline experience. Are you seeing that? I don't think you're going to say that, but just give us your perspective.
Okay, well, thanks for having me on the panel. I have 8 pages of critical talking points here that I want to get across. I know I only have about 10 minutes to do it all, so I'm gonna, I'm free to talk to anyone who has more questions later. I think about this for most of my day, and I've been doing that for about 25, 30 years. But I think there's some important context that we need to sort of back up and start with, which is COVID was really bad for primary care. It was devastating, and a lot of people quit because of COVID and stopped working. And being a primary care doctor through the era of COVID, before we had the vaccine and even after we had the vaccine, was incredibly traumatic. People have basically PTSD from dealing with the primary care issues in COVID. And it's really only been over the last 2 years that we've come out of that. So our trainees, our residents, our medical students who are just graduating right now from their residencies, they were trained during COVID, and that's a hard place to train. Other things that have been dramatically different over the last few years that have, are context for what's going on right now in the state. We have new leadership at Care New England, new leadership at Brown University Health, new leadership at the medical school. All of those new leaders have made deep commitments and investments in primary care, and that has helped quite a bit. The third thing is, one of the biggest problems in primary care is the documentation burden, and AI scribes have been transformative with that. So there are lots of things unrelated to state of Rhode Island health policy that are impacting what happens in primary care. Yeah, and so there's lots of things that are impacting what's going on. Healthcare policy is an interesting thing. I think it's a little bit hard to see those impacts yet. Some of the newer legislation has only very recently been enacted. I'll start with just the issue of the prior auth. You state prior auth 100% eliminated, but that's just not true. It's not true. It's a soundbite that sounds great, and I'm excited about getting rid of prior auth because prior auth is a pain in the neck. But the reality is that patients on Medicare are not covered by any of these prior auth laws. So if we see a patient on Medicare, we still have to do the prior auth. Medicaid has a different law than commercial insurance. So you have to think about, is this a commercially insured patient or is this a Medicaid patient? Because there's different rules. And if you're employed by a large employer that self-insures but works through Blue Cross Blue Shield or another large payer, they're not covered at all. So the actual number of patients that this applies to is small. The complexity of the law is real. And now we have our staff trying to figure out who has to be prior auth and who doesn't, and keeping track of multiple laws and multiple sets of patients and legislation. So on the ground, does it work? We haven't really seen it implemented in a way that seems to work yet, but we're hopeful. We're thrilled that Blue Cross Blue Shield started to do the elimination of prior auth early without any legal issues at all, and that did help us. But it's a complex world that we live in. We're embedded in a federal system, and so all of these attempts to make things better are complicated and don't necessarily get to the point where we think they should get. And it's important to recognize that complexity because sometimes the sound bites hide more problems.
I think Martha maybe she could jump in for a quick second.
I just wanted to say one thing, if I could, because I totally agree with you. And what we did at Blue Cross when we eliminated 65%, it was across all lines of business. So we were not trying to make, the rule that then came out, and this is one of those situations where I think the Assembly's trying to be helpful, but maybe don't understand that it actually drives some complexity. So what we did for 65% was every line of business. And we can talk about why it was 65%, not 100%. It was important clinically. But anyway, so I agree with you because one of the things I learned on primary care is we drove everything being consistent across every payer, across every line of business to ensure that we didn't have to change the clinical workflow depending on who the patient was. And I think it's just a really important part of how you make clinical care work better and not have to have clinicians be thinking about how is this patient insured.
Yeah, I think that would work if we only saw Blue Cross Blue Shield patients.
No, I mean across, but there's ways to line this up. Well, ours was for Medicare Advantage, other lines of business. I'm just saying there's ways to line up the rules so that they actually are the same.
There's ways to try that. We haven't succeeded in lining up the rules, but we're working on it. We're trying. Everybody's trying to make this better, but it's an incredibly complex problem. And we have to be sort of realistic about what we are achieving and what we're able to do. And why we're still struggling, honestly. Although things there are good signs and things are getting better, we are still struggling. It's a free country, mostly for most people still. And when you get to the end of your MD degree and you walk out of medical school, you have choices. You get to choose what you choose to do with your life and what residency you choose to do. And the reality is that if it's people don't go into primary care because of the money. It doesn't pay very well. And so there's other reasons that people go into primary care, and we need to make sure that works. We're talking about efficiency.
And I wonder if you could also comment, you run one of the largest family medicine residencies. So now you've chosen the medical students who said, look, I want to go into primary care. They're the ones who don't care about the money. They finish up their residency. They're in your office. The speaker Martha talked about, we need to keep them in Rhode Island. Give us a sense of their perspective of why do I choose to stay here in the state versus leave the state? Because I think you have a really great view on that because everyone wants them to stay here in the state.
We have 15 residents in family medicine who are graduating in July, and 5 of them are planning to stay in Rhode Island, and an additional 3 will go outside of Rhode Island to Massachusetts or Connecticut to do fellowships and probably will return. Many of our fellows train and come back. And then a large number of our residents go outside of the state. Some people live in Rhode Island and work in Massachusetts or Connecticut because they get paid $100,000 more when they drive across the state line. So there's lots of reasons why people stay and why people don't stay. I think if we're talking about efficiency and we're talking about, the burden of documentation, we're talking about what it's like to actually practice team-based care, those kinds of things, those are really important to our graduates. Most of our graduates and many practicing family docs are backing off of full-time work because it's simply too hard to see patients full-time right now. You can't keep up with the paperwork. So lots of people are practicing, 0.6 FTEs, 0.4 FTEs, and then doing something else with their rest of their time or just catching up on their paperwork with the rest of the time. That's a really important factor as well. But I think one of the things that it makes primary care efficient is continuity. So if we see the same complex patient over time, it's much easier for us to take care of that patient, and we get 20 minutes to see a patient. If they have a lot of health problems, a lot of complexity, and we've never seen the patient before, we cannot possibly do a good job with that patient in 20 minutes. So we either take an hour and get way behind and everyone yells at us, or we do a bad job. Either way, there's a moral injury, it's unpleasant, nobody gets good care, nobody likes it. When we see the same person over time with continuity, with a trusted relationship, building rapport, we can do a 20-minute visit with a really complex patient because we already know the story. We already know the risks. We already know what we need to focus on over time. And because patients open up to us more and tell us what's really going on so we can help deal with real problems. The current situation with our informatics systems, electronic medical records, has really done a disservice in terms of continuity and relationship building and trust. COVID didn't help with that either. But we're starting to rebuild. We're starting to focus on continuity. We're starting to really focus on making sure doctors have a panel that they can identify, that patients know who their PCP is, and those are the things that change outcomes. They change, in particular, hospitalization rates. They change ER visit rates. They change health outcomes, continuity changes, preventive services as well. So that's what we're working on right now.
And Jason, you wanted to jump in with something?
Sure, just a quick thought, and I'm anxious that Caroline not divorce me as a friend. She's a dear friend of my wife and I. But I also don't want to be an apologist for prior auth as it's implemented today. But I do want to flag that, in a sense, there's no free lunch, that there's a trade-off between premiums and utilization. And to the extent that there's inappropriate utilization, and there is, there are absolutely instances where docs or other primary care providers or other folks, it might go to a high-cost option before trying a plausibly successful lower option. I'm not trying to say that any of this is good, but there's a trade-off here between eliminating utilization management and keeping a lid on premiums. Like, there's no free lunch.
I think you have to look at complexity here again. When I have a patient in my office who needs a head CT, and I can't get the prior auth through, you know what I do? I send them to the ER because they get their head CT that way. So prior auth doesn't always decrease utilization. Sometimes prior auth increases utilization. When I have an asthmatic patient who can't get the prior auth for one of their medications, you know what happens to them? They get hospitalized. Yeah, they have an unnecessary ambulatory sensitive hospitalization. So prior auth, you can talk about how it reduces utilization. In many cases, it increases utilization.
Martha, you want to jump in as the on this?
Sure. Well, I think prior auth, we have to find the right balance. And so CT scans are the kind of thing that shouldn't have a prior auth for them in the situations you're talking about, or an asthmatic getting their drugs. And so talking about where you're running into that would be interesting. I would say, from my perspective, if I come back to what Blue Cross did for primary care, the reason we did 65% of all prior auths that we eliminated, but not the remaining 35%, is because that was MRIs. And what we see in this state is we see 30% higher than benchmark use of MRIs. And by the way, we see a 25% higher rate of orthopedic surgery in this state than our neighboring states. And so we're just doing a lot more volume of certain types of procedures. The other example that I would give you is when GLP-1s first got introduced, and people wanted them for obesity, but they weren't covered. They were only covered if you had diabetes. What happened in this state is the increase in the rate of people who had diabetes doubled. And I have a lot of empathy for the PCPs who decided to say that somebody was diabetic because they're getting tremendous pressure.
You're implying that we said people had diabetes who didn't have diabetes?
Well, what happened when we then
That's crazy.
put a rule in place that said you had to show documentation like an A1C is then it cut back in half. So yes, there was some of that where people were saying, oh, maybe somebody's actually pre-diabetic, but they're near diabetes. And so that's what the data showed, is that when we actually then require the documentation, it dropped back down.
I'm a diabetes researcher. I came to Rhode Island 3 years ago and saw just horrendous care for our patients with diabetes. We didn't have enough endocrinologists. We had a whole bunch of people who were labeled as type 2 diabetes who actually had type 1 diabetes and weren't properly managed. We had people dying of renal failure because they're poorly managed diabetes. We've dramatically improved the care for our diabetes patients, partly by increasing GLP-1 prescriptions and SGLT2 inhibitor prescriptions for our patients with diabetes over the last 3 years. So I think there was a underdiagnosis problem and an undertreatment problem that may have gone along with what you were seeing.
Well, and it might be different populations that you're talking about as well, so it may be worth looking at that. We're talking about the Blue Cross Blue Shield population specifically, which tends to have better access to care than lots of populations. And as somebody who spent 7 years in renal care, I absolutely agree with the importance of the assessments, with the diagnosis, with the care. Otherwise, obviously, we get lots of other downstream issues.
Yeah. So I wanted to turn to the speaker right now, but I think the prior auth conversation is a great point, because we talk a lot about the complexity and pain that primary care clinicians are experiencing. It's one example of that, but it also, this conversation highlights how difficult it is to try to address that there. But speaker, you want to jump in? There you are.
Back on. I want to say this is great, and I appreciate the different points of view and the different aspects of it. But this is what we deal with at the State House constantly. I feel like I'm at a hearing. I mean, this is it's so true. It's everybody comes up with their point of view, and they feel extremely passionate about it, and they're usually right to most of the degree, but they fail to take in the other side of the view, or they fail to balance it. And this is the challenges that we have. And I know earlier I recognized the House colleagues. I know there are a couple of senators here. I want to recognize Senator Urso from Pawtucket, Senator Uji Fusa as well from the East Bay. All of the things we do, we need the Senate as well. No one person or one chamber does it alone. So it's a collaborative effort. But the point I want to make is that what you're hearing here today is what we hear at the State House regularly on every issue. And this is what is our challenge. And by the way, it's not always an easy one. It's very rarely easy, and we don't always get it right. But this is the challenge, sifting through conflicting data. And then you layer on, and I mean this in a very appropriate and positive way, layer on lobbyists who are, really paid amplifiers, and they do a good job, and they play an important role for us because we're a part-time legislature with limited staff, but who also only amplify their client's point of view. And it's up to us as policymakers, as elected officials, to go through this and sift through this conflicting points of view to craft a policy, a comprehensive policy, a collaborative process that brings all of these point of view to the table. Now, not everybody wins, not everybody loses, and not everybody gets part of it, but we try to at least everybody gets considered. And if I have to say no, and sometimes that's the job as a speaker, is to say no, I try to explain and give a reason why. And when I have a legislator or a lobbyist or an advocate come to me with anything about any issue, I say to them, go talk to the members, go talk to the other side. This particular chairman or chairwoman doesn't like it, go explain why, how come, see their point of view. I want to constantly challenge my colleagues in the General Assembly to listen to different points of view. Because inevitably when they craft a bill, they put a bill in, they're doing something, it's their point of view or one side's point of view. They have no conception. And when they do that, you're much easier to get to a compromise. Yeah. Thank you.
Thank you very much, and I think it's a critical perspective, just the balancing act that you have to place. I think a lot of the folks in this audience are going to be interested. We've talked a lot about so many changes that have happened, and changes that have been implemented in the last year. Where do we go from here? And I was wondering if you could give us a lens from the Assembly, as you have your crystal ball, what policies, issues you think are going to come up in this legislative cycle, the cycle after that potentially, and maybe specifically on this topic that you raised, which is how do we keep, Caroline described 5 out of her 15 graduates are coming out and staying in Rhode Island. How do we increase that to 6 or 7 or 8 or 9?
All very good points. The short-term crystal ball is we have to make sure that the Centurion deal closes, because that will loom as a big guillotine over the General Assembly if the deal does not close by March 1st and that the state ends up through a receivership taking over those hospitals. You're talking about hundreds of $millions that we don't have. The $18 million rescue package that we passed yesterday is not state money. It is a pledge of state money from our rainy day fund, because we don't have, that's how tight our budget is, $18 million hanging around. It was a very creative way to help these hospitals sell these bonds without, at least in this fiscal year, writing a check, which ends June 30th. So where do we go from there? We continue to do this process. We listen to you. I think that a lot of programs in the General Assembly have been working. We like to look at, people say, how do you make a decision on what to fund? I look at programs that work and programs sometimes that have a federal match or even an outside match that we can do this. I think the medical school is a long way off. It's not an overnight solution, but we need to continue to look at that. We have some really good programs in the state for loan forgiveness, and we help keep doctors here by saying if we forgive some of your medical debt that you incur to, if we forgive 5 years of it, you have to stay 5 years, or some form of that. We're going to explore that. I don't have, people say you have a lot of money. I don't. The governor puts his budget together. He spends every dime of it. He sits at the General Assembly. We get our revenue numbers in May. A better time to answer that question would be in May, and I'll know what we have. We could have less money, which means we're going to be cutting from the governor's budget. We could have more money, which means we will expand as we can to do that as well. There are proposals in the governor's budget for the so-called millionaire's tax, but he's already spent that. He's already included that. That's not extra money or free money that comes in. And that also goes into effect the first of the calendar year, so we would only get half of that this fiscal year, if in fact that we went that way. We'll have to wait and see. And I'm ever hopeful, I'm the eternal optimist, that we have an incredible federal delegation, and Jack Reed, Sheldon Whitehouse, and our Congressman Magazina and Amo fight very hard for Rhode Island, and I've seen them deliver for Rhode Island in an oversized way. So every time that I run into them, I go, any chance for anything, it doesn't have to be healthcare, it doesn't have to be housing. Can we get more money to the state? Because all money is fungible. If we get rural health money, that gives us a little bit more money to maybe put in, don't get excited, Paige, into a child care program. Yes, Elizabeth, you too. We don't need that. And I can go around the room, but where's the money going to go? It's going to go into health care. Where in health care? That's such a broad term. That could mean hospitals. That could be hospital systems that are looking for money. We have a birthing center, a Samuel Center, that are under a lot of pressure right now that are being threatened to be shut down and closed. Yeah. The birthing center in Newport, the Samuel Center does free and reduced cost dental services in South Providence, and I can go on and on as far as the needs go. We're going to continue to see what's available and reallocate and resources as we get them, and continue to work with Martha, by the way, who's been an excellent partner, because responsive. When I asked her and her team to supply information to the General Assembly, she steps right up. Within a week, it's there, it's in their desk, it's in their inbox. And it's that collaboration, that communication that makes all the difference. We're also studying the energy costs this session. That's a big issue in the General Assembly. How are we addressing that? There's a huge rally today at the State House regarding our renewable energies. Are they good? Are they bad? Can we change them? What do we need on that? We're looking at creative ways to reduce energy costs, utility bills for Rhode Island. Healthcare premiums, in spite of the benefits we have, is still going up. We don't know what's going to happen with the health exchange. You know, food insecurity is a big issue.
Yeah.
Those are the crystal ball issues, and it's cloudy, and what you can see out through that clouds are not good pictures right now.
And you're highlighting one of our next panels, which is on affordability, which is something so central. Martha, you want to jump in?
Yeah, first of all, thank you for your partnership. And with so many people around this room, we work really closely with them. And we do really try to bring fact to the conversation and to try to be balanced. And I think it's really important that we bring data to everything we're talking about. I wanted to say the other area that I think we're really optimistic about collectively is that rural healthcare fund, because there's money in it for practice transformation, and we really should figure out how we do it to address some of the issues that you're raising, Caroline, because we have the second highest funding per capita in the country. I don't know how that happened, if Trump wasn't paying attention, but somehow we got basically as much as Massachusetts for this fund. It's a tremendous opportunity right now. And practice transformation is exciting. Moving to team-based care, as you said, that many of the folks coming out are interested in participating in. What I have seen with really good team-based care is that physicians are able to sort of get off the hamster wheel, right? The trying to see patients and catch up and not have the continuity and always being behind. When you actually have a full complement of a care team, you can then risk stratify the population and get the people who are most acute to the physician. You can get the people who have significant diet issues to a nutritionist. You can get people who are having trouble accessing nutritious food to the social worker who can help try to address that. You're able to use nurse practitioners to see somebody for a well visit. It is a way to take the care team and use them to optimize the care. And not only is it better for reducing burnout for the PCP and reducing the number of hours that they're on call, but it's also better access for people, because instead of waiting for longer to see the PCP, you might be able to get in right away to see, for instance, the nutritionist. And so it makes the whole system work better. And one of the things we do is we fund pharmacy experts. So having a pharmacist with all the complexity of drugs right now is an incredible help to primary care physicians. So I think we have to think about, what does that whole complement look like? How do we fund it? How do we get better training for nurse practitioners who don't have the experience to necessarily operate at the same level, but can operate under the guidance of a physician or their own panels, but they need more help, more training than they're getting now. Our Primary Care Physician Advisory Council is really energized about this and thinking about ways, potentially even with Brown or others, that we could fund more training, more fellowships for nurse practitioners to get them more, better equipped to see patients.
So I'm looking at the time. I'm going to pose one more question, and then if folks from the audience want to come up and ask some questions, please. I think there's some mics in the back, and we can ask some questions for the panelists. I want to build off Martha's question and turn to Caroline. So we're in 2026. We see the headlines every day. AI, everything's transforming. And there's this sense out there that technology is going to make your life a lot easier, Caroline, and your fellow primary care clinicians. You mentioned ambient AI. As you look at the landscape of both what's in your own practice, what's coming down the pike, what you're hearing from your colleagues, what things get you most excited about potentially how can technology potentially make the day-to-day life of a primary care clinician a lot better?
I'm an early adopter. I think AI has the potential to be really transformative and make a big difference in primary care, but not the way everyone thinks it does. The way that AI is being deployed in medicine right now is really focused on things like rare diagnoses and risk stratification. And when a 470-pound, 60-year-old man comes into my office putting out a cigarette with his Dunkin' Donuts bag in his hand and tells me that he hasn't had any chest pain for a while, but had an MI 2 years ago, I know what his diagnosis is, and I know what his risk is. I don't need a risk stratifier and I don't need a diagnostic engine to tell me what's going on with him. Most of my patients are like that. I'm not saying that occasionally I don't turn to AI to try and find a diagnosis for somebody that's confusing to me or complex or has weird symptoms. But most of the patients that walk into my office, I know what their diagnosis is when they walk in the room. And I know what their risk factors are. Or I can get them pretty quickly and pretty easily. So the tools that I really need are the ones that help me maintain a continuity relationship with my patient that's a trusted relationship over time, and make sure that things don't drop through the cracks. That helps me with documentation, getting patients what they need, making sure the prior auths go through on the medications, which are not covered in the bill, by the way. And so I need tools that help me do my job. The nice thing about AI scribes is that it's not so much that I don't have to sit at home and write my notes at the end of the day for 3 hours. It's that when I see a patient, I'm looking at the patient, talking to them and listening instead of typing. So those are the kinds of ways that I see AI tools helping primary care. Unfortunately, there's not a lot of effort going into the kinds of tools that we need. It's sort of, as with everything, it's being sort of pulled off into what subspecialists need, what hospitalists need, rather than what primary care needs. But we're pushing back on that and trying hard to get the tools to do what we need them to do.
Great. And looking for some questions in the audience. And Jason, by the way, while we're waiting for that first question, do you wanted to jump in a little bit earlier?
Sure. It was just a thought about what the speaker was alluding to in the discussions about adding a second medical school in the state. I just want to, big question that comes to my mind is where does the state get the most bang from its buck? And would it be something like adding residency slots, subsidizing residency slots, maybe in family medicine where we know folks are going to go into primary care by definition? Just that to the extent that dollars are limited, my sense is they are, what is the best use of them? And it might not be a new medical school.
Yeah, can I just jump in on that? Yeah. So there is a residency, a plan for a new family medicine residency program at Thunder Mist and Woonsocket. We have a good partnership at Brown and Care New England with Thunder Mist, and we supported them in their application to get that residency approved by the federal authorities that regulate ACGME rules and slots. They succeeded in getting that approved, but then it wasn't funded. So they didn't put money in the budget for it, even though they said, yes, we approve these slots.
You say it's we, it's the federal government.
Federal government, okay.
The state approved matching funds to help support it, and it wasn't funded by the federal government, so it isn't happening. Unfortunately, our training slots for family medicine residency programs and every other residency program we have are regulated by the federal government and capped. And funding is, that should come from them, is not supporting the things that we need in the state. And pushing back hard on getting those residency slots funded is a really important thing, but it is a federal government issue, not a state government issue. And it requires federal government approval. So I think there's opportunities that we have that the whole state, everyone in the state is supportive of, that would really make a difference. And there's really good data that residents tend to stay where they train, or relatively local to where they train, rather than medical students who tend to go all over the country. So I think 90% of people who go through a family medicine residency practice primary care. Family medicine investment is important for the state. We have one family medicine residency program in the entire state. That's the Brown Family Medicine Residency Program. It's been here for 50 years. It's trained a lot of the primary care doctors in the state. We need more.
I don't disagree. I hear you. I will tell you the medical school is a long-range solution, if we even get there. I think what's being proposed is to use bonding money along with a lot of other bonding projects, so it's not revenue money that we use every day. I like to consider all of those. It's not, to me, it's not one or the other. It's not a medical school or residency slots or funding a program. Could we use possibly this federal rural grant for that? I would hope so. I don't know yet. We're waiting for guidance. We have really talented people in the House and Senate and the governor's office reviewing that and seeing what we can. I can tell you this, it's not free money. It's not, here's $156 million, spend it in the umbrella of healthcare. There are very rigid requirements. and we have to make sure we follow that, or we surrender the money, or we get penalized, and we don't want to do that. So I hear you all. I understand that, but you're competing with RIPTA, who want money for public transit, and I can go down the list, and you're competing with a whole host of other advocates who are very, very skilled at electoral politics and working to help elect people who get elected with a single goal of helping that particular cause, or whether it's nursing, or you're competing with a lot of other people for those same revenue dollars. And it's our job, and it's my job, and all of us who are elected to make those decisions, those tough decisions, because they're all good causes. They're all good people. They work very hard, whether it's behavior medicine, whether it's dental medicine, whether it's dental reimbursement rates. You know, there's always a never-ending quest. David Cicilline, a good friend, we talked about him earlier, the Rhode Island Foundation put a report out. Oh, we have to change the funding formula for education. Sounds good. It's $300 million. It's $300 million. I mean, I don't have $300 million. That's not in the governor's budget, but we need to take a look at that. So there are a lot of other needs and asks and requests within the budget. And there's also an incredible amount of asks outside of the budget.
Let
Can
me.
I just say in the meanwhile, let's take those federal funds that we just are newly getting and let's use them to support primary care, because I think we can do things to transform.
If we can. If we can.
It's in the.
Yeah, but
whereas
what I'm trying to say is we need federal guidance.
Mr. Commissioner might know.
Yeah. So we need
That's a
federal
good
guidance.
segue. Let me.
I'm not opposed to it, but it's not free money, Martha. We
not
have to follow a process.
Nothing's free. Nothing is free. I'm hearing that loud and clear from this.
Corey,
Free from
just wanted to jump in
restrictions.
with a question there. You can explain how we can use the money and also ask a question.
I have to defer that to EOHHS, unfortunately. Good morning, everyone. I'm Health Insurance Commissioner Corey King. Great panel discussion. I want to make an observation, which I'm going to translate into a question for Martha. She's used to taking questions from me. So the observation is this. There's a tension that has been surfaced in this panel discussion. Healthcare purchasing and oversight in the United States is fragmented across state and federal governments. It creates constraints around the reach of state health insurance laws and regulations. I have this conversation with Senator Ujifusa all the time. How many Rhode Island residents are we impacting by passing state health insurance laws? So what was referenced on the panel was the recent action by the General Assembly to suspend prior authorization when ordered by a primary care provider in the normal course of delivering primary care. Also mentioned was the regulation my office passed last year requiring an increase in investment to primary care. But the self-insured, which are part of the private market, they account for 65% of Rhode Island residents that have commercial insurance. And they are beyond the reach of state health insurance laws, mostly. So I ask this question, in a small state, Martha, how can we go about building the momentum and engaging with self-insured employers to get them on board with paying an enriched fee schedule for primary care, to get them on board with voluntarily eliminating their prior authorizations, particularly when our universities, healthcare providers, and state and local governments are some of the biggest self-insured employers? So that's the question.
It's a really good question. One of the things that the insurance commissioner knows is that when that increase for primary care rates went through for fully insured, we as Blue Cross went to all of our self-insured customers and said, will you opt in to paying the higher rates? You don't have to, but will you opt in? And we went to all of our customers, including all the health systems who employ many of the primary care physicians, and they all said no. Blue Cross said yes, because we felt we needed to, even though it created a bunch of friction with our employees, because they're in high deductible health plans, and so they're paying a lot of that upfront cost, at least in the beginning of the year. And we decided to do it, but the reason that entities didn't was for really good reason, which is healthcare costs are so high and premiums right now, rates are so high for self-insured customers. They are feeling so pressed. So this went, I believe you spoke with Dr. Wagner about this. This came to him as a specific decision about whether to support this, and he did not feel like he had the flexibility to do it. So, as an example, so I would just say, we all want to support primary care, but then we actually have to put our funding behind it. And the bulk of the challenge in the state is the low Medicaid rates. If you look at the population, while yes, the majority of commercially insured might be self-insured folks, unfortunately, in this state, we've had over a 30% decline in the percentage of people that are covered by commercial insurance and an 80% increase in the percentage of people covered by Medicaid. So you do the math. You can't make up for the shortfalls in Medicaid on the commercial population. It's just not mathematically possible. So there's got to be support. We've got to find the money. We've got to take it from other places, maybe within the Medicaid budget. There's other trade-offs we can make, to your point on how rich the benefits are. But we have to address the Medicaid funding issue, or we're going to continue to have instability in primary care.
Thank you. Let me, first of all, let me say this about Corky. Excellent question. I'm going to add another wrinkle to that in a minute, but I want to just call people's attention. There's not many things that we do well in state government, but Corey King is one of the stars of state government. He does a phenomenal job. The man, the myth, the legend. When I first heard about him, I thought he was like this 75-year-old man with horn-rimmed glasses somewhere behind him, and he's like a young whippersnapper. But here's the problem with that. Here's that problem with that. Governor Raimondo tried to address this issue several years ago in her administration. It was like 8 years ago. She wanted to penalize very significant companies in Rhode Island. I don't want to say the names because everyone will know them here, who actually coach their employees not to go into the company plan because they make the deductibles high, they make the premiums high, and go into the state plan because it's cheaper for them. Unfortunately, that's the cost, and that's the kind of the crux of the whole problem. We have too many people on state insurance in Rhode Island, and not enough people, just to identify what Martha said, in the private plan, which pays more reimbursement rates to doctors. It's like 2/3, 1/3. We're upside down compared to our neighboring states. And that is the problem. How do you do that? How do you get businesses to stop coaching their employees to go into the state plan? And Governor Raimondo solution didn't go anywhere, and the businesses actually woke up and came out. They don't come out for much, but they came out for that. Was that you're going to hurt businesses? This is bad. But they were actually embarrassed when you published the numbers of how many people are on state insurance who work for some of the biggest and blue chip companies in Rhode Island.
Well, and I know you've been really focused on how we drive economic growth, because that's the big answer here, is more jobs with commercial insurance are going to help providers the most to stabilize.
You're right. It's a balancing act. At the same time, I'm going to complain to these private employees and trying to get them to do what Corey King and I think is the right thing to do. I'm asking them to expand, and I'm asking them to grow their businesses. And at the same time we're doing that, we want to tax the high earners. So it's a constant balancing act of that, of trying to keep business here in Rhode Island, recruit business, keep businesses growing in Rhode Island, but making sure everybody pays their fair share into the system. With that, I have to go.
Yeah, and we are out of time. We've just scratched the surface. We only got to some of your notes, Caroline. I feel bad that we didn't get to a lot of your other points, but a lot of discussion to continue. Thank you all for your engagement in this topic. Thank you to the panelists, and thanks again.
So hello, everyone. I am Andy Ryan. I'm the director of the Center for Advancing Health Policy Through Research. I'm so thrilled that we are hosting this event today, and I'm just reflecting on that first panel, which was really exceptional. It was honest, it was substantive, it was entertaining. Actually reminded me a lot of Kid Rock's halftime performance. Right? Okay. You guys didn't see it? You didn't see it? Oh, no. Okay. All right. So I'm moderating the second panel about affordability in healthcare with the emphasis on Rhode Island. And obviously, we previewed many of these issues in the first panel, but I'm just going to give some stage-setting remarks here, just noting that I think that healthcare affordability is really having a moment in our country. You know, when Americans are polled about their most important concerns that they're facing, healthcare costs are routinely at the top of that list. We've seen healthcare spending now grow to 18% of our economy. It's projected to keep going. We've seen debates in Congress recently about the extension of the enhanced premium tax credits that I think focused on two core issues. Number one, what role should the government play in continuing to subsidize health insurance? And then two, what explains the underlying levels of healthcare costs that are driving these massive increases in premiums? And so this is the kind of tension I think that we would really want to talk about. You know, in Rhode Island, we've seen rate increases for 2026 that are nearly 20% across a number of segments. And I think it just kind of leaves us looking for questions, to answers to important questions like, you know, do these recent increases in spending suggest that there's something really broken about healthcare or healthcare system? Or on the other hand, are these spending increases, the premium increases, really reflective of new treatments, new care that's valuable to patients, that's good and we should accept? And even if we do think that this is valuable care, at what point is it unaffordable? We just simply, we can't pay for it. And so these are, I think, some of these fundamental questions, not only with respect to affordability. I think the real issue is, to whom? Are we talking about affordable to patients, employers, the government? I think in the short term, we can think of the government picking up a larger share in terms of subsidies, but then over the longer term, you know, healthcare costs show up somewhere. It's either going to be in higher taxes or lower wages or somewhere. So really balancing that tension about how to make healthcare affordable in the short term for individuals through subsidies while also paying attention to this longer term view, I think, is absolutely central. Last stage setting point is really about Rhode Island and what can we really expect to do here in Rhode Island? How much can we control this trend? How much can we exert influence on healthcare spending? To what extent are we just along for the ride with larger factors that are driving these trends? So this is what we're going to be discussing in this panel, and I am joined by several esteemed experts here. Lindsay Lang is the director of Rhode Island Health Source, our health insurance exchange commissioner. Corey King, director of the Office of the Health Insurance Commissioner, and then my colleague, Erin Fusay-Brown at the Brown School of Public Health, director of the Health Law Lab there. So I'm actually going to start with Corey, Commissioner King. And so as I mentioned a moment ago, we have seen for 2026 approved premium increases on the order of 20% across several segments. And as the insurance commissioner, Corey, is this your fault?
That's an excellent opening question. Before I answer that, I want to just thank Caper for the opportunity to be here. I'm really excited about what Brown is building. I've been a policymaker, I've been at OHIC now for almost 12 years. And actually, my path started at Brown when I was a graduate student there, and I met a guy named Chris Kohler, who was the health insurance commissioner, and now I have his job. It's great. But I've used the work of Erin and Chris Whaley. I'm not sure if Chris is here. And then all of a sudden, they were in our backyard, employed by Brown. So it's really exciting, the team that you've built.
Sometimes consolidation is good.
Consolidation is good in this instance. Certainly, I have a responsibility when it comes to the health insurance premiums that are approved every year. One of OHIC's fundamental tasks is to do prior approval rate review. And the Rhode Island statutes lay out how the commissioner makes his or her decisions. The rates set forth have to be consistent with the proper conduct of the insurer's business and consistent with the public interest. I'm not given any more detail than that, so I have to try to intuit or interpret what that means in light of this significant problem that's presented to us, and that is we get a rate filing where a health insurance company asks for an increase. Last year, the rate increases that were filed were the largest I'd ever seen, certainly. I think they were probably the largest that the office has ever seen. Big increases were not unique to Rhode Island, so I don't feel a major concern that we're doing something uniquely bad. But I'll tell you what we found in our rate review. And our rate review is very detailed, and it's done in accordance with state law. We've seen over the last few years, from 2021 to 2024, while earned premiums per person per month have grown at an average annual rate of 4%, the incurred claims that the insurers pay has grown at 5.8%. So their costs are increasing faster than the premiums that we are giving them. That leads to some degree of rate deficiency. Consumer cost sharing, which is outside of premium, is growing at the highest average annual rate over that period, 6.5%. So there was some existing premium deficiency built into rates, compounded by future-looking increases in utilization, severity of services, and reimbursement rates. Those are part of the picture. Like, the increases for primary care are part of this picture. So ultimately, we do our review, we bring them down a bit, but I have 3 broad constituencies that I have to satisfy in a rate review. 3 broad constituencies. First, insurance companies have statutory reserve requirements. If they fall below those reserve requirements, they are subjected to greater regulatory oversight, and eventually the insurer may be rehabilitated, liquidated. We don't want an insolvency event in this state. It would have a cascading effect on our healthcare system. So the insurance companies are a constituency. The providers are a constituency. Rhode Islanders' premiums are, by and large, providers' revenue. 84 cents on the dollar is ultimately paid to providers, hospitals, physicians, pharmacies. We can have a lot of debates about how that's allocated and whether the market is appropriately allocating resources. And then the third constituency is the consumer or the employer. Can they afford to pay for healthcare? And that gets to the affordability problem. So it's complicated. I'm absolutely open to constructive criticism that perhaps my decisions don't meet the appropriate balance of those 3 constituencies, but that's what we confronted.
Okay, thank you for that, Corey. So, you talked about this prior rate deficiency and that this has kind of been building, and to some extent that's reflected in the new premium increases, but are there other significant sources of medical spend that are on your radar that have really contributed to, these historic rate increases?
Yeah, so there was a unique instance within the individual market where we had the highest approved rate increases. That was due to the expiration of the enhanced premium tax credits, and Director Lane can speak very eloquently around that, where it's expected people will drop coverage that will worsen the risk pool, and therefore you'll just have a higher overall average premium. And that added about 4 to 5 points to those approved rates. But by and large, when we look at the premium and we decompose it into its medical and non-medical components, the medical component follows a similar story year for year. Inpatient facility and outpatient facility services account for about 45% of that healthcare dollar. The next biggest area of expense is professional providers, followed by pharmacy, and pharmacy is growing as a percentage of the whole. So it's looking across all of these, there are cost drivers. There's a combination of, we've been seeing increased utilization in some areas, particularly professional provider utilization for behavioral health services. That has been a cost driver in recent, but again, not necessarily bad, we'll get to that. And then rate increases. We have this rate discussion, what we pay Rhode Islanders in relative to Massachusetts and Connecticut, but insurance companies, in the commercial market at least, they negotiate multi-year contracts with built-in rate escalators, and those flow through premium. The last point I'll make, kind of just to package all of this together, is the statutes that created the Office of the Health Insurance Commissioner require the commissioner to discharge the powers and duties of office to view the healthcare system as a comprehensive entity and direct insurers towards policies that advance the welfare of the public. I may have missed a word or two. It's a very long directive, but viewing the healthcare system as a comprehensive entity is absolutely critical. We measure Rhode Islanders' healthcare spending, and in our most recent year of measurement, 2023, we comprehensively measured $9 billion of healthcare spending on behalf of Rhode Island residents. Over 2/3 of that is funded by government. Different rules, different circumstances. Again, that ratio isn't necessarily unique to Rhode Island, but I'm operating within a system with legal constraints and institutional constraints around what I can do. The commercial market follows more of a market-based system for allocating resources. And then all of the government payers, Medicare and Medicaid, those are largely administratively determined rates prices. And administratively determined does not mean logically determined or well determined, but that is a fact. And we have to account for the significant share of Rhode Islanders that are on those government-funded plans. And I think there's pressure on the commercial market to increase funding and rates and premiums to make up for some of that prior rate deficiency on the other side.
Excellent, thank you, Corey. So let me turn to you, Lindsay, and just ask you to reflect on the experience of Rhode Islanders trying to purchase insurance with the exchange in light of HR 1 and the new federal policy environment, and just what that looks like to you.
Sure, and thanks so much for having me this morning. Great to be on this panel and with you all. So the ACA laid a great framework, and Rhode Island really took that framework and put it to use and put it to work for Rhode Islanders. We've seen a 3/4 decline in the rate of uninsured over the last decade plus that we have had the ACA and a state-based exchange here in Rhode Island. That said, over the last couple of years, that enhanced tax credits have been in place and available for folks who purchase through HealthSource or I. We've seen progress we didn't dream of about a decade ago in terms of enrollment. Our enrollment increased about 60% over these last couple of years, going from 30,000 to 48,000 through the individual and family program on HealthSource or I. We historically had about 80% of our customers receiving that tax credit, and I'll use subsidy, advanced premium tax credit, sort of interchangeably. The point being that with the additional subsidy, with that additional enhanced tax credit, more people were able to get help every single month affording their coverage. Like I said, that went from 80 to 90%. And that made a real difference. It really, folks say it put the affordability in the Affordable Care Act. What that looked like for our enrollees, what is now about an average premium of $172 was about $110. Folks who are subsidized in 2025 saw their rates increase on average over 100% when they went to purchase coverage for 2026. For some people, it was much higher than that, 200, 300% increases, depending on where you fall on the income spectrum and your age. And so that is going to have an enormous impact. Maybe not right now. Our enrollment is pretty good. We just closed our open enrollment period 2 weeks ago. But it's going to have enormous impact longer term. We're keeping an eye on that in terms of folks' ability to hold on to their coverage with time. When you are somebody making $25,000, $40,000, and you're being asked to pay $50, $100, $300 more every single month, that's not sustainable, particularly with the rise in other household costs that we all know and are familiar with in 2026. So that is important to be aware of. We project that in 2026, we could see losses of 13,000 enrollees in the individual market as people drop their coverage due to affordability concerns specifically. Another thing that we'll be watching is how it's going to impact what type of coverage HealthSource or I customers are able to purchase. I think we'll get a little bit more into that later on in the panel. But in addition to just increasing the number of Rhode Islanders who are able to get health insurance over the last couple of years, that tax credit also enhanced their purchasing power. So when they came through HealthSource or I, they were able to pick from among a spectrum of plans, ranging from bronze level with a lower premium but much higher out-of-pocket spending during the year to a platinum level plan with a much higher premium but much lower out-of-pocket spending. And so we're really seeing a reversal, unfortunately, of the level of plan that Rhode Islanders are going to are enrolled in, and how that will impact their access to care and their longevity in that care and whether they're able to hold on to it. And then just lastly, you mentioned HR 1. This isn't even a part of HR 1, right? This just coincided with the passage of HR 1 last June. The enhanced tax credits were set to expire at the end of 2025, and unfortunately, as we're all aware at this point, they were not able to be extended as part of the federal budget negotiations. So this is just, layer one of the onion as we start to see the rest of HR 1 play out and impact access to Medicaid, access to coverage through the marketplace, and importantly, how people move in between Medicaid and the marketplace. And Rhode Island in particular has done a lot to support that movement and support Rhode Islanders retaining coverage when their eligibility changes in between those two programs. So a lot to come in the coming months and in the coming years with the rest of the HR 1 changes.
Excellent, thank you, Lindsay. I really appreciate the big picture perspective on the coverage gains that we have experienced in Rhode Island. It's not all bad news. Many people have acquired coverage that would be otherwise unaffordable. But I think your point about, not only are people losing coverage through the higher premiums, but they're opting into less generous coverage, and that will potentially affect their experience down the line across a whole range of domains with the healthcare system. That's something really important to watch in this next year. I think that's a great observation. So let me turn to Aaron. So we've kind of heard, some of the big picture trends and constraints and that kind of we're facing under current law in Rhode Island. And Aaron, I'd like to hear from you, your view about kind of, in general, state-based approaches to affordability. And, it's kind of my view that states are kind of just like fed up and they're like, we got to do something. And then in many ways have been more active and aggressive, but then also, as has already come up with Corey's question, through ERISA, limited in many ways. So, I'd love to hear from you just, what's the landscape look like with respect to state efforts to address spending?
Yeah, so the states have been watching the affordability crisis in healthcare long before it became the buzzword of like 2025, right? So states have been doing a lot of thinking, and in some ways, I think the observations that that Lindsay made and that Corey has made has really heightened the idea that states are dealing with this from, it was bad even when affordability was a problem, even when there were enhanced premium tax credits, even when there was no Medicaid work requirements, even before all of the sort of like current crises that are unrolling on state budgets and unrolling in the state healthcare systems, coming down from the federal government's budget cuts, basically, or funding cuts. And so I'm sort of looking back and being like, oh, it was so nice to work with states when like all you had to worry about was like how consolidated is your healthcare system, how much are your dominant hospital systems, health systems, and provider groups able to charge. And so really it's a consolidation, it's a supply regulation issue. And it's still obviously healthcare costs, and particularly hospital inpatient and outpatient costs, are still the main sort of like contributor to rising premiums, rising healthcare spending, but now we're also contending with like people just losing their coverage altogether, and the federal dollars that subsidized access and affordability for many people just drying up. So it's like now we're dealing with this on two fronts, as not just on one. And so I think that keeping that in mind, sort of before, when assuming people had coverage, and just like how do you manage premium increases and affordability, the name of the game was all about states trying to use their powers to control either further consolidation of the market, provide some market oversight so that actors within the health system can't just get bigger and charge more and more and more, that someone's watching, right? There's cost growth targets, there's market oversight programs to prevent just endless consolidation. But for many states, that's like a little bit too little too late. There's already so much consolidation in the healthcare system that prices at the top of the market are virtually unconstrained, right? There's no market force that's keeping those prices contained. So many states have started to look at various forms of price regulation. And Rhode Island was actually one of the innovators here with the affordability standards through Corey's office that constrains hospital reimbursement rates to as a growth cap, basically saying hospital prices baked into the premiums can't grow faster than the rate of inflation plus 1%. And that has really constrained hospital prices in Rhode Island relative to basically, everywhere else. Of course, there are, I'll get into this later, there are some trade-offs here, right, in terms of the sustainability of the hospital system, sustainability of we're dealing with the potential instability of 2 safety net hospitals here in Rhode Island, and a lot of that story has to do with what you do to constrain price growth has real knock-on effects for the hospitals in the system. Other states are looking at similar but different models. And so I think looking at sort of the laboratory of experiments that the states are putting forth is a great place to learn. One of the things that other states, including states like Indiana and Vermont, have put into place, sort of pioneered by Oregon in its state employee health plan, is just a flat cap, not a growth cap, but a cap, basically a reference-based price on hospital, inpatient, and outpatient prices as a multiple of Medicare. So basically, like, reverse engineer what would sort of only affect the top of the market, those that have the market power to charge, super competitive prices, and really just cap them and force them down below some multiple of Medicare, and then leave the safety net providers more or less untouched. Unlike a growth cap, which constrains, potentially everyone in the market. So we've seen, states experimenting with those. These were just implemented in the last legislative session, so they're still rolling out. Oregon's been living with this for its employee health plan for quite some time and generating some savings there that are significant for the state budget. And then another version of this that we're seeing is no state has passed it yet, but states are toying with the idea of establishing something called site-neutral payment for the commercially insured market. And New York had a bill last year. We're working with other states on their bills this year to do something similar. But basically, it's to pay the same price for a certain set of outpatient services that can safely be provided at the lowest cost setting, usually an office-based setting or ambulatory care setting, instead of paying this sort of extra hospital-based price, even if it's offered at a hospital outpatient department. So that's a way of saving money, again, on a certain subset of services that's really potentially considered maybe waste or at least unjustified extra spending. So states are really moving not just into the let's oversee the market, let's measure, let's name and shame. All of that can potentially have some impact, but states are saying enough is enough. We need some constraint, some administrative constraint on the market side, the commercial market side of healthcare prices. And as I alluded to earlier, Rhode Island was an innovator in this space and in some ways was sort of wildly successful in containing our growth rates of our hospital prices. But now we're starting to see that that's actually having different effects on different segments of the market. And so I'd love to hear what Corey's reflection of that is.
Sure. Thanks for introducing that. I do think, and I agree, we've been working for the last few years with a dozen states that are all committed to affordability, and price tends to come up. So when we think about what drives healthcare costs, what drives premiums, there are 3 factors. There's the use of care, there's the site of care, and there's how much it is priced, what the unit reimbursement rate is. And of those 3 factors, the factor that's most controllable to market participants at the negotiating table is the price. That's what's known at the beginning of the year. Utilization depends on a number of factors, people's health, accidents, things like that, and then how providers go about furnishing care. So you, Brown, and particularly Andy, you were a primary author on an evaluation of the affordability standards that was published last May, and it found that through a relative reduction in hospital prices, meaning our prices grew slower than the national comparison group, we had achieved a $1,000 per person per year savings. So premiums for a family of 4 would, in the counterfactual scenario, be $4,000 a year higher had we not implemented the policy. But there's a trade-off. And as part of my work, I see trade-offs all over the place. I think in the previous panel it was described as a balancing act. If you want to pay providers more, there is no free lunch. I think someone observed that. It has to be paid for by someone. We don't always determine as a society who pays for it in the most optimal manner. But in recent years, we've been pushing on increasing investment in primary care. There's a cost to that. We've been pushing on, our colleagues elsewhere in state government and from the federal government have been pushing on behavioral health parity, bringing up the reimbursement rates for behavioral health providers. There's a cost to that. A few years ago, for those hospitals, Roger Williams and Our Lady of Fatima, Landmark also benefited from this. My office passed regulations, I was not a commissioner, Marie Ganem was commissioner back then, to require commercial insurers to increase their inpatient reimbursement rates for those lesser reimbursed hospitals up to the network median. And some of them saw sizable rate increases. But you were speaking to this issue of payment variation, right? So there are haves and there are have-nots in healthcare. And some of the folks here may disagree with that characterization, but you've got some providers that are paid a lot better than others. And when the office applied that price growth cap linked to CPI 15 years ago, it was applied to a distribution of prices where Miriam, Rhode Island Hospital, Kent, Women and Infants were the best paid. Roger Williams, Our Lady of Fatima, Landmark were the worst paid. Variation in price is the norm, not the exception. You see it all over the place. But when we applied that growth cap, the assertion has been that the lesser reimbursed hospitals aren't able to catch up because they can't grow faster than the cap. But that underlying payment variation was the consequence of a long-running, unregulated, market-based system that produced those very outcomes, where it's differences in market leverage, big payers, big providers that can negotiate what they want, little payers, little providers that have less ability to negotiate. So those hospitals that we talk about today tend to have higher government payer mix, or they're part of smaller systems and don't have the ancillary services built around them. So when I look at the counterfactual of rate regulation in Rhode Island, my question to folks would be, if we didn't apply that hospital price growth cap, what makes us think those hospitals would be better off today from a rating perspective? I submit they wouldn't, because the biggest providers, Brown University Health, Care New England, would use their market leverage to negotiate good rates with commercial payers, and then commercial payers would use their market leverage to push down rates where they can. To ultimately keep premiums in check and try to address affordability.
Thank you, Corey. Let me just follow up real quickly on that. So, there's two ways to think about this. There's the counterfactual, what if the standards had never been done? Where would we be? How much more would we be spending? But then we could think about other counterfactuals that kind of Aaron alluded to, what if, you had mentioned that this kind of seemingly perhaps unwarranted variation in prices was an issue. This is something we see across the economy, something we also saw in Rhode Island. But is this, first of all, you seem to suggest that's undesirable. Maybe you could confirm that. But then second of all, could we get to a place where, that variation was shrunk further, perhaps by moving off a growth cap towards more of a level cap, which is what, we have seen in a number of other states?
Sure, and I don't want to dominate the discussion, but I do think that it's fair to have discussion about substituting one system of price regulation for another and understanding the effects of that. At the end of the day, though, I think that we need to look comprehensively at how these hospitals have ended up where they are from a rate perspective, what the other payer contributions in the state need to be. There hasn't been a discussion or recognition that 10 years ago, Medicaid rates were cut. Not that their growth was capped, they were cut, meaning reduced. During the first Trump administration, the imputed rural floor was rescinded. Medicare rates were cut. That imposed hardship on our hospitals and our healthcare delivery system. We are certainly aware of that. From a rate distribution perspective, I would actually look to research from people like yourself to understand what proportion of that variation is legitimate or justifiable. After all, Rhode Island Hospital has to have 24/7 access. Anyone here could get into a car accident at 3 a.m. in the morning and have to go to Rhode Island Hospital, and they have to have people there to treat you. So definitely look forward to working with you on that to understand whether there's a more sophisticated approach we can take to rate regulation. Wouldn't necessarily be my office. I've been surprised, frankly, that there hasn't been a broader effort in this state to create a hospital rate setting authority. But I think that some providers in the market might view that a bit differently than others. Let's just say that.
Thank you, Corey. Aaron, I want to turn to you because we've had this discussion about provider prices, and this is where a lot of the action is. Let's try to regulate prices. And there's kind of this assumption, mechanistically, the point isn't just to cut provider prices. The point is to put that money back in someone's pocket, either the taxpayer or the purchaser. And so, what can you tell us about this relationship that we kind of refer to as pass-through? You have some reduction in rates, and what can we expect for this to get back to the consumer? I think it was, I don't know if it was Martha or Caroline talked about, primary care payment increases don't necessarily just go straight to the doctor. This is a thing about healthcare. There are these intermediaries. It's complicated. So could you maybe help us understand, what this looks like, what we know and what we don't know?
Yeah, and actually Corey's question on the last panel really teed up this issue very well, and this idea that the state only has regulatory authority over a small segment of the private health insurance market, and that is the fully insured market, and to some degree the state employee health plan and other public employees. But really the vast bulk, I think it's 60 to 65% of people who have private health insurance coverage through their employer are covered by a self-funded, meaning the employer keeps the financial risk for covering that plan. And so for all of these self-funded plans, there's this law called ERISA. It stands for the Employee Retirement Income Security Act of 1974. It was designed to regulate pensions and retirement, and it's become this big healthcare regulation because health benefits offered by employers are also covered by ERISA. And really what it says to states and state regulation is that there's very little states can do to touch and to make employers who cover their employees do anything. They cannot regulate these self-funded employer plans. And a lot of times the justification is these are for large multi-state employers. They don't want to have to worry about complying with 51 different state laws when it comes to their employee benefits. So the argument is, they want to offer one plan. They want to offer, one product. They are keeping the risk. And so then they hire what looks functionally like an insurance company, but it is a third-party administrator to just administer the plan. But there's very little states can even do to regulate the TPA, this third-party these middlemen. We don't even have visibility into the TPA functions. So one of the things, this study that Corey mentioned that Andy was the lead author on, that looked at the Rhode Island affordability standards, all the savings from the Rhode Island affordability standards were more or less fully passed through if you happen to have fully insured coverage in Rhode Island. And almost none of it was passed through if you had self-funded coverage in Rhode Island. And there's almost nothing the state of Rhode Island can do. There's nothing Corey can do or even our legislature can do to force the self-funded payers to pass on those savings. And so where is that savings going, right? It's going to the middlemen, it's being kept along the way, and maybe they're saying, well, it's being dispersed into our national, all of the national costs of covering our employees all across the country. So it's unreasonable to expect it to be passed through, but really we can't even see where it goes. We can't even follow those dollars. And what we know is that the state just has limited, very constrained ability to regulate the vast majority of the commercial insurance market, particularly on these things like you can do all of this, eke out this savings, and it's really meaningful savings. It's like, potentially affecting someone else's revenue. It's potentially affecting the stability of our provider market, and then that savings just gets pocketed along the way and for the vast bulk of the commercially insured market.
I mean, just to make this concrete, something that we've talked about is this idea that a big self-funded group like Home Depot operating in Rhode Island, for instance, like, they're paying lower prices for hospital care, but the way that their premiums get set will be kind of nationally equivalent across all the Home Depot stores. So they might be saving a little bit of money in Rhode Island, but that doesn't necessarily mean the Rhode Island employees are paying lower premiums, because as you can think about it, this being community rated across their entire book of business. So I think this notion of like, who pays the cost and who gets the benefits from these caps that are done in states, I think is really important. And this transparency is certainly first order here. We've been talking a lot about the supply side, regulating the supply side of care providers. And let me just turn back to Lindsay here, because, in some sense, recent years, last decade plus, there's been a real emphasis on, I'll say the demand side as a tool for, cost reduction, about giving consumers, skin in the game, high deductible plans, making them thoughtful about the care that they get and not getting things they don't need. And, I guess maybe I will just ask you, you're welcome to talk broadly about kind of these demand side experiments and how well you think they've worked, but in a specific way, when you think about people getting insurance coverage and this notion of like them having the information that they need to be the kind of consumers that we're expecting of them, how can you speak to, what you've done through HealthSource to try to enable that?
Sure. So I would first and foremost say this is an area that we have long wanted to do more. Can remember specific conversations several years ago about how we can help develop our customers into more empowered consumers, both of the products that they were shopping and comparing through HealthSource or but then as consumers of health services over time, how they can better understand the product that they've purchased, often the largest or one of the largest purchases in a household in a given year, and use that product in a way that we would want them to, both in terms of using the healthcare system in lower cost ways, but also from our perspective, wanting to help them fully harness the value of the product they've purchased and want to continue to purchase it and come back year over year. We have not done as much, as I've mentioned, with active education as we would like. It's been a struggle for a number of reasons, one of which is the constant destabilization at the federal level, taking our attention off of these initiatives, and just spending more time than we would wish talking to our customers about how those changes are impacting them and why they're seeing cost increases why they're seeing out-of-pocket expenses increase over time. But I will talk a little bit about what we do. And, most folks in this room will know that our mission is to increase access to high-quality, affordable coverage. One of the ways that we are intended to do that is by serving as a marketplace for customers to shop and compare plans side by side, to better understand what makes a health insurance product differ from product to product, and then ultimately to get the services and supports they need to pick the one that best meets their needs and that they will find value with. And so we do that in a number of ways. First and foremost, through our application process, which is largely online and self-served, we compare plans side by side, breaking them down into their components, helping customers understand network, standard plan benefits, co-insurance, co-pay, et cetera. So many of us are used to that shopping experience now. We see it everywhere, from Amazon to Home Depot to Travelocity to you name it. But a decade or more ago, that was certainly less standard, and our goal was to come in and create that shopping experience. So we do that through the online experience. We also produce a plan and benefit brochure that does that in hard copy. You can sit down across the table from someone helping you select a plan and very objectively compare health insurance products in a way that it was really hard to do beforehand. We also have a cost calculator which customers can shop through anonymously, or it's embedded in our application process. And that's really geared towards helping customers understand what their costs will be both upfront and then through their experience throughout the year when they go to point of service, to help them balance that upfront cost with the risk that they're managing, that they may ultimately need to use that product, and what will it cost them when they need to do that throughout the year. Again, trying to get at the value and helping to communicate how to use this health insurance product as a way to stabilize their finances, a way to plan for the unknown in the year ahead. And then we automatically renew customers year over year. That's a huge benefit, we think, to our customers and to our operations to ensure that we make it as easy as we can to go from year to year, but we communicate what the change in the plan will be if we need to map them to a new one, what the change in cost will be. And we wrap around that with some targeted outreach to ensure that if there are customers who are in certain plans, that they really should reconsider. In particular, certain income eligible folks will be eligible for additional cost sharing reductions. If they're not in a plan where they're benefiting from that, we're going to outreach to them and have a conversation about why it may make sense to reconsider. And then conversely, if they're in a silver level plan, but they're not eligible for those CSRs, we'll reach out and say, hey, you know, you may want to look at a gold level plan, a richer plan that's going to protect you from higher out-of-pocket expenses throughout the year. It's really going to be about the same or maybe even less, given that we silver load in the state of Rhode Island. So a number of different ways that we've been working to just help consumers understand the product. Unfortunately, we haven't been able to go much beyond that, but we would really very much like to do that. With an application process, it takes about 40 minutes, unfortunately, and then a plan selection process that takes about 20. It leaves little room to add more in, but we'll continue to push into that area.
Right. Just a quick question on this. I mean, people have been purchasing insurance on the exchanges now for over 10 years. I mean, are people actually getting better at it, or are we still kind of square one?
That's a great question. So we have seen, and this could be a product of auto enrollment as much as an informed consumer, but we have seen folks who are eligible for certain cost sharing reductions where they need to be in a certain metal level plan, choosing that at a higher rate than we once did. Another way that we measure this is through our customer satisfaction survey and our health insurance survey. Customer satisfaction is done annually, HIS is done every other year, and we're trying to get at questions about your satisfaction with the plan you've enrolled in, your plan shopping experience, and your experience throughout the year. And we have seen those scores increase over time, which is great. In particular, we take pride in the confidence that the plan you've selected is the right one for you. And while I don't have those numbers in front of me, I know that that has improved with time, namely in the last few years, which also is a product of the enhanced tax credits and that increased purchasing power that I mentioned. But we do keep an eye on it, and those scores have improved over time.
Great. Thank you, Lindsay. So I want to zoom out a bit, get back to some of the questions I set up at the top before we get to audience questions. And so, you know, I mentioned this question of like, how should we think in a broad way about these increases in spending, increases in premiums? Is it good? Is it not good? And I want to ask each of the panelists a question. I'm going to give a hypothetical, and you must answer. So this is it. So would you prefer to have 2026 medical care at 2026 healthcare costs, or 1965 medical care and 1965 medical costs. Like in my household, we play a lot of would you rather. So this is kind of like, would you rather?
I'll be brave. I'm going with 2026. Clearly, 2026 healthcare, 2026 incomes, et cetera. As a health economist, maybe have some others in the room, you know this. When you look at the long expanse of history going back to the 1960s, the key driver of our increase in national healthcare expenditures has been technological change, right? New goods, services, new ways of doing old things, which I think have led to better outcomes, but it doesn't mean we can't reproach the current practices for how we allocate resources in the market and try to solve for those through use of regulation. But I'm taking 2026.
Okay.
I will second that motion. I think we've all benefited from advancements, innovations in healthcare. Personally, from advanced imaging, from genetic testing. Don't think we want to go backwards from that. But I think the key question that's been brought up in both panels is affordability to who. Costs. Who's bearing the cost? And as the richest nation in the world, we need to have those hard conversations and have the political leadership to answer that question and make those hard choices. So 2026 all the way.
All right, I'll also say 2026, but I'm going to pick I'm going to say that doesn't mean that 2026 is ideal, right? It doesn't mean that we've hit the right balance. And part of it is that we cover way more people, not just more technology, but we also there's just more access. So in some ways, I kind of would like to go back to 2024 healthcare, but because there's more people in the pool. But even that, the allocation is not ideal, right? Like that is the what are we getting for our money? And then maybe it's like to zoom out and say, well, why do we have to restrict our imagination to what we do in the United States? There are lots of other countries that are wealthy and developed countries that spend much less than 18% of GDP or per capita on healthcare and provide as good or better healthcare, including technology, adaptation in other countries than we do. So I think that we have a long way to go, both to maintaining access, equity, but also constraining our choices of like how we just sort of thoughtlessly adopt new technology without sort of like dwindling the supply of primary care physicians, of safety net hospitals. And I think one of the issues, and this is teeing up the third panel of the day, is that we really can't do any of this without confronting sort of the payer mix differential, the fact that if you're poor in this country, hospitals and physicians are paid so much less to take care of you that this can't be, it's not a sustainable system. And at the same time, we have people who are even just being kicked out of Medicaid altogether because of budget cuts. So I think in some ways it's like taking the systems level approach. Yes, I guess I would pick 2026 over 1965, but I think we have a long way to go to make 2027 better than 2026.
Let me follow up. So, Corey talked about medical technology, Aaron did too, and we've talked a lot about prices, provider prices, but Corey also mentioned at the outset, pharmaceuticals as being a big driver of recent spending increases, and that's what I think of as a classic, new technology, okay, in healthcare. It's just in a broad sense, new technology, new pharmaceuticals, and so, we can, again, this whole balancing act is like, we're getting some amazing drugs, GLPs have come up, but then we're getting lots of new oncology drugs that, I don't know how people think about it, but it's very expensive with maybe pretty marginal value, frankly. And so I guess I want to ask, this hasn't come up yet, but, pharmaceuticals are a big part of, national spending trends, and are there things that states are doing? Are there things that states should do? Or again, are we just riding the wave here and we're gonna just follow the leader and just be subject to whatever costs and benefits come downstream?
Yeah, I mean, pharmaceuticals are sort of a huge area of cost growth. And states have been, again, working at this issue almost more furiously than they've been working at the hospital price issue. But there's, again, a very limited range of tools states can do in a federalist system with the supremacy clause where federal law governs the incentives, the patent terms, the FDA approval process, the Medicare and Medicaid coverage rules, pricing. So, there are some attempts to do, say, prescription drug affordability boards, PDABs. There are other things that states have done. They've been legally challenged every step of the way. So they're trying to pick a course. But this is one of those things where the pharmaceutical market is one that is almost more so than the hospital market, which is a local market, something that states have very little leverage over in terms of actually constraining the factors that are driving prescription drug prices.
Yeah, it's incredibly frustrating as a regulator when you're trying to cut down a health insurance rate hike, or you're trying to think about how you systemically bring down medical trends and you don't have clear levers over drug prices. And I think that puts more pressure, quite frankly, on your local providers, your facilities, your physicians, is the place where we try to make up for the sort of unbalanced nature of that affordability equation, where the Rhode Islander can't necessarily afford the care they're getting. And the fact that other countries pay such significantly lower rates for the same drugs indicates that I think there's an opportunity there if we could get some federal action behind it.
All right, so we'll shift to audience questions in 1 minute, but I have one last question for the panel, and this is another hypothetical. So say, we look out 5 years and healthcare is more affordable in the state of Rhode Island. We've achieved some bending of the cost curve, imagine. And so, what is the most likely explanation for this short-term success? What would we have done?
I'll answer that in a few ways. I think some smaller ways around the margins include continuing efforts to keep everyone covered, particularly in the commercial market. That's going to be critical. We've done a lot in Rhode Island in terms of defense against federal instability to stabilize the market and keep people in the pool. And I think that's just going to be sort of baseline, really critical if we're going to continue to pursue other cost containment initiatives, is just keeping our very small market in the market to the greatest extent possible. I think there might also be some opportunities as a small state to think more strategically across our public purchasing power, looking at our MCO contracts, looking at our state of Rhode Island employee contract, using the marketplace's purchasing power to pursue so many of the policies that have been discussed en masse, more so in the future. And then more broadly, AI was discussed on the first panel in terms of providers, but I think there are also going to be opportunities to leverage AI, perhaps to reduce more of the back office costs in the administrative aspect of healthcare and the management aspect of healthcare. So really looking forward to seeing that really come into play in the years ahead.
So that's a very good question. I think unless for some reason we invert all of prior history and the economy starts growing faster than healthcare, then we're not going to be able to grow our ways out of it. So we have to continue to tackle the drivers of healthcare costs. It's going to be a mix of policy initiatives. There's not a silver bullet here. Aaron is very well versed on antitrust enforcement. That's going to be a piece of it, so you can guard against increasing consolidation. But I got to tell you, the bar for antitrust is extremely high. It is not something you can solely rely upon, because the very studies that the antitrust regulators rely upon to challenge mergers and acquisitions is based on mergers and acquisitions that happen. And when they happen, costs go up. And when costs go up, workers end up taking a pay cut, because at the end of the day, healthcare costs ultimately drive premiums. Employers try to manage that, and it shows up in reduced wage growth. So if we're going to manage this, it's going to be a combination of state efforts. I think price regulation has to remain a piece of it. I think that some of the issues that Director Lang raised around subsidization, but again, someone has to pay for the subsidies, those enhanced tax credits, as just an example. And maybe in 5 years, we'll have figured out the pharmacy pricing issue.
Yeah, I think if you were to say, you know, we have somehow bent the cost curve in 5 years, what do you guess happened in that time period? I would say there was a change in administration at the federal level, and the Medicaid funds are restored. You know, work requirements went away. Enhanced premium tax credits were restored. So, but that's a cheat, right? That's saying that the federal sources of funding that are subsidizing making care accessible and affordable would be returned. That doesn't take the onus off the plate of the state to figure out how to manage rising healthcare costs, even under that, with that you know, excess spending that's coming in or additional spending. So I would say, yes, I agree with Corey that there has to be some form of price regulation. Maybe it can be, you know, a tweaked version of what we have now. There needs to be increased Medicaid rates to support, you know, the entire spectrum, kind of compress the distance between Medicaid rates and commercial rates, so that this sort of there's more, you know, there's just more in the system for taking care of the have-nots in the both among patients and among providers. And I think that there's just, you know, in terms of the market oversight beyond antitrust, is to really think about preventing new forms of consolidation that are happening, and giving the authorities more ability to challenge, stop, block, not even have to go to court to stop transactions that are new and novel, whether it's you know, outside investor groups that are rolling up physician practices or outpatient clinics, and those types of things that are where the new antitrust trend is moving towards vertical consolidation and the like. I think we need to sharpen our tools there as well.
Thank you. So, questions from the audience. Linda.
Yes, thank you so much, everyone. My question is, in terms of affordability, what kind of research is being done looking into the middlemen insurers and pharmacy benefit managers, the countries you named that are doing so much better than we are, have a single payer system, and that is the major difference, why they have about one half the price per capita and universal coverage and better health outcomes. So are we going to be looking at the role of middlemen insurers and possibly deprivatizing Medicaid?
Erin?
Andy? Yes, we are certainly at CAPER. That is one of the areas that we are very much interested in, is looking at trying to even, let alone tackle, but even put a number on the amount of our healthcare dollar that gets siphoned off along the way by all of the middlemen. As Jason pointed, Jason in the back on the first panel is working on this issue, and you know, and he was saying, you know, we have these data problems with, you know, figuring out how many primary care providers. We think the data problems are so much worse with figuring out, like, even the black box of the middlemen. So we're trying to crack open that black box. We're trying to be creative, but you're absolutely right that there is a lot of administrative bloat in the system from all of these middlemen, and I think we can't even begin to understand how to move our system towards something that is more coherent and more efficient without understanding just how much we're wasting money on the middlemen.
Well, let me just follow up there. I mean, how much do you think we can just build on the price negotiation authority that's in the IRA? Like, is this going to start getting us close to addressing Senator Ujafuza's concern, or is this still, is the PBM middleman problem just distinct and needs to be addressed in a distinct way?
I think in some ways, I mean, having price negotiation in Medicare through the Inflation Reduction Act is like a huge step, right? Because in some ways, like, Medicare prices have spillover effects on the rest of the market. And so, you know, that's, I wouldn't say that it's not the whole solution, right? Because it's not all the drugs, but I think it's a really important constraint to be able to pair price regulation, which we have not traditionally had in Medicare on drugs, with more, again, more regulation or more sunlight on the middlemen, in this case, the PBMs, and the incentives they have to, to basically do all the spread pricing, rebates, and all of these things that are, again, funding a huge industry. And a lot of our healthcare pharmacy dollar goes to middlemen that, are not necessarily funding innovation or not funding new technology that will save lives. So again, yeah, I think it's a bit of both and.
I'm under the obligation to briefly plug Article 11, Section 1 of the governor's proposed fiscal year 2027 budget, where we've put forward some proposals to get at the rebates, administrative costs of pharmacy benefit managers, and be able to ask them questions about their business practices and how they develop networks, and do they engage in spread pricing, and then at the end of the day, prepare a report for you all as legislators to give you some ideas on how to go about tackling this. So transparency, I think, is the first step on that. But in concept, I agree with you. There's a lot of money out there. I think there's some money out there that we can probably use more efficiently.
Please, Martha.
Sorry, I'm back. Aaron, you said in the future, 5 years from now, when things are better, we'd have narrowed the gap, I think, between Medicaid and commercial rates. Is there any work underway to actually look at Medicaid rates? One of the challenges we have in the state of Rhode Island is we actually don't know what the Medicaid rates are. I know at times that the insurance commissioner has been tasked by the Assembly with doing analysis on a portion of the spend on social services, but when you actually look across, we actually don't know. We know that Medicaid rates are lower, but there isn't data that says it's this much lower for this type of service than that. And so we aren't actually able to then go in I think a clear way to the Assembly and say, here is where it needs to be addressed. At least that's a challenge for all of us. So as we think about how do we raise, for Our Lady of Fatima and Roger Williams and some of these health systems that are under so much pressure that have a predominant Medicaid and Medicare mix, we got to figure out what the data is. And there's so much health economist knowledge in this room, but it's like we haven't really pointed our power, it seems like, at this question quantitatively.
I can try to take a stab at that, Martha. So as you mentioned, OHIC does reviews every 2 years for a subset of Medicaid providers, behavioral health, home care, early intervention, et cetera. So we do have a very good inventory of what those rates are. And we've seen in some instances they needed to go up 30, 50%. I think there was one rate increase. We recommended a 75% rate increase 2 years ago. You obviously appropriated funding for that, so that we're appreciative. On primary care, some of the data I've seen from our APCD showed that prior to the Assembly increasing the primary care rates up to 100% of Medicare, they were running at about 60% of Medicare. That's not including FQHCs, whose payment methods are different. I think the tremendous black box around Medicaid, commercial, Medicare payment is within the hospital setting. We have the RAND report looking at commercial and Medicare, but when you look at Medicaid reimbursement rates, the statutory increases, the state-directed payments, what percentage of Medicare would that equate to? We don't have that number. At least I don't have that number. I'd love to see it. And I think that would be a good future task to do analytically.
Hi, my name is Marcia Nyberg. I'm with Brown University Health. I just want to build a little bit on Martha and maybe think a little bit more regionally. So we've talked a lot about there being these discrepancies between not just Medicaid, frankly, and commercial, but Medicare and commercial as well. There's, depending on where you are, very large pricing variation. We, in this state, we've talked about being small. From a population perspective, in some ways, we're no smaller than Montana. It's just that our state boundaries, our lines are tighter. I wonder if there is thinking out there about a more regional approach to both the regulatory framework that could help states band together to start to put pressure on the federal government to address some of these things, and if there's any thinking you all have done around that kind of thinking. And I'm just thinking of starting in New England, where every time you cross a border, you cross a regulatory line, and that's a lot of work, actually. That's a lot of paperwork, and that drives a lot of cost.
That's a great idea, and particularly I think because the geographic scope of a lot of the New England markets they're really just across the border. I mean, they're functionally, to a patient and to a provider, they're functionally the same market. And so I think that the idea of I believe there was some attempt to have talks of sort of a New England consortium of states. I know that there's been talk, at least on the pharmacy benefit procurement side of things, there's like a northwest consortium of states that are trying to do sort of pharmacy benefit management regulation and procurement and drug pricing as a banding together the states, and so trying to address some of this like across state lines of it all. I think there are challenges in terms of, each state has its own, it's hard enough to get the actors within one state to coordinate and talk to each other, but I think that there are certain particular pockets where that might make the most sense from just a purchasing and an organizing standpoint.
Yeah, just to piggyback on that, aligning laws across different state legislatures would be incredibly difficult. So many of them are part-time. I'm fascinated and have been fascinated by this question of market definition, because we hear it a lot. Well, the market is New England, the market is Boston to New Haven. At least that was the assertion that Dr. Babineau, the previous CEO of Lifespan, made. But we had an instance a few years ago when we had to define the market to review a major transaction, the Lifespan Care New England merger, and the Attorney General, who, by the way, wrote one of the most incredible and important regulatory decisions in the state's history, denying that merger request, hired an economist to look at this question. What is the market? What is the market for hospital services in this instance? And they defined the market as Rhode Island, maybe a little bit of Bristol County, Massachusetts. They were beginning to build a monopsony case, right? Look at the decision. It's a fascinating read. A couple hundred pages of the Economist report, 150 pages of the AGs. But when they were looking at the market for nurses, it wasn't Boston to New Haven. So I think we have to be careful about talking about what our product markets are. Maybe it's broader for physicians, right? For a pediatric dermatologist, maybe it is Augusta, Maine, down to, New York City. But that's a critical question. And I've always said on this regional rate variation piece, if we want Rhode Islanders to pay Boston prices for healthcare, they need to be paid Boston wages. Otherwise, they will be economically worse off, all else equal.
Thank you. I think we have two more questions.
Hello.
Hello.
Hello. I've been selling health insurance in Rhode Island for 25 years. I have experience in most segments, and we are in troubled times, clearly. I would suggest when I am in a room with my colleagues like I am today and I listen to banter about how to fix the issue, I think one thing is getting overlooked, and that's the difference between health care and health insurance. And if you can break those things down, then we might have a better way to move forward. Thank you.
All right, thank you. Is there a question over here?
Thank you. I am Robert Millett with Estrana Health. Those of you that don't know us, we previously were part of the Charter Care System, Independent Physician Association, part of the Charter Care System. About 120 PCPs we represent in an integrated specialist group too, attempting to be. So the question is, we've heard a lot about rates, and we've heard a lot about, from both panels, and a lot about the pie and the size of the pie. I don't think it's obviously any epiphany for anybody in this room. The size of that pie is not growing, it's shrinking, and it will continue to shrink. We haven't talked a lot about the efficiency of the delivery system from a policy perspective. I go there as an ex-hospital finance lead in a big academic center. I think about the lack of efficiencies that we had there and our inability to really kind of break through and get at that waste that is in really the entire country. In particular, I'll specifically go to, folks, it's no secret that 30 to still 35 to maybe even 40% of the people that end up in an ED and end up in a bed shouldn't be there. We talked about ambulatory sensitive conditions earlier. Connie, the physician, mentioned it. We don't talk about that stuff enough. So I'm curious from a policy perspective where the group lands about the efficiency of the delivery system here in Rhode Island and what we can do from a policy perspective to address that.
I can take a crack at that one. I think addressing the efficiency of the delivery system, and let's talk about efficient use of services. There's efficiency in other dimensions as well, but I think that's the role of value-based payment. And there's been a movement over the last decade to develop value-based payment models, total cost of care arrangements, to get providers to think critically about, site of care, for instance, and to be able to share in some of those savings. So I think that can be a catalyst. What are the efficiency targets? Like, I don't have that level of detail or information out there. We hear like the things thrown around, 1/3 of use is wasteful. I'm not sure if that's the right number. But there's definitely opportunity to leverage savings through more efficient use of lower reimbursed sites of care where it's equally high quality, and also preventing higher levels of care, like having to send patients to the emergency room to get that CT scan.
I'm gonna have to. So just a couple comments about this. I think, this perspective has very much undergirded so much of payment reform in the United States since, the ACA and this whole idea that we're inefficient and wasting care. And I think it's one of these things. It's like, okay, while it's true, it's been this maybe a very difficult challenge a priori. I mean, if we knew what was wasteful, it's the whole thing. If we knew that someone was going to die anyway, then we could eliminate end-of-life spending, but we don't know. And I think, searching for this, like, waste, I think you can see it, like, after the fact, but you don't see it before the fact. And I think that's just this so much inherent uncertainty in medical care just makes this, like, super challenging. Like, from a utilization perspective, if you compare the United States with our peer nations, it's like, we don't go to the doctor more, really. We don't go to the hospital more. What we do more is we have higher prices and we use certain technology more, and that's like really the delta. And so, I think there's a bit of a, I certainly admit and would concede that there's lots of inefficiency in healthcare. I think, and when we get back to this question of like, what's really driving spending growth, what's the essence of the problem? My question would be, is efficiency just getting worse and worse and worse, and that's responsible for, our where we are now, or, are there other factors that have really contributed to the growth, and that's where we should be looking rather than trying to kind of dial down? And I would say with value-based care, not to disagree with Corey, but we've been studying this forever, and it's been so hard to find. You find maybe a little bit here and there. We've really been trying with all kinds of initiatives, and not only has it really, I think, failed to generate a lot of savings, but back to like Caroline's point and stuff, there's just so much admin burden that goes with setting up the benchmarks and asking PCPs to kind of manage care, asking them to do lots of things that's not just being a doctor. That's been a huge part of the shift. It's made primary care difficult. And so I just think there's this whole trade-off when we go towards, changing towards, VBP, alternative payment models, that is not necessarily neutral on the system. So I can get off my soapbox now. But, that's part of how I view this efficiency idea and how much juice there is to squeeze there, even accepting that it is certainly an issue in U.S. healthcare. Mark, you want to go ahead?
Thanks. My name is Mark Ryan. I've been a primary care physician for 41 years. I, like many of my colleagues, have burned out recently, and I'm contributing to the shortage of primary care providers because I don't provide it anymore. Among the billion things I'd like to say, there's so much emphasis on people wasting care. Most of my patients do not want to see me. They do not want to go to the hospital. They would rather stay home. And when you look at national analyses of our healthcare system, over 30 of them by groups like the Kaiser Family Foundation, the Robert Wood Johnson Foundation, the Urban Institute, all pretty much agree that 1 out of every 3 healthcare dollars actually vanishes before it's used to deliver any care whatsoever. And it's consumed by the multitude of insurance companies with the bureaucratic overhead they generate, as well as the excessive pharmaceutical prices that each individual insurance company does not have the economic power to reduce. And that's where a lot of the waste is occurring. And unfortunately, we can be as informed consumers as we want, and it's not going to affect those numbers at all. Thanks.
Okay, thank you, Mark. So I believe we are at time, as much as I think we'd all like to keep going here. So please join me in thanking this tremendous panel today.
Good afternoon. I'm Melissa Clark. I'm a professor of health services policy and practice and the director of the Survey Qualitative and Applied Data Research Core at the School of Public Health. And I'm also proud to be the scientific lead of the Rhode Island Life Index, otherwise known as the RI Life Index. So in 2019, Blue Cross and Blue Shield and the School of Public Health partnered to create the index as a data-driven approach to capturing Rhode Islanders' perceptions of the social factors that affect health and well-being, along with a few questions about lived experiences. So for the last 7 years, we've been tracking these trends and making the data publicly available to community-based organizations, service providers, public officials, and anyone else who is seeking to make a difference in the lives of Rhode Islanders. For Blue Cross, the index serves as a driver of their mission to improve the health and well-being of Rhode Islanders by leading access to high-quality care. The index also serves as an annual credible community guide for their philanthropy. Together, Brown and Blue Cross know that consistently fielding the RI Life Index, we're helping to create a shared data-driven tool that can inform decision-making, spark dialogue, and guide action across sectors. It equips people in influential and policy-making roles with insights they can use to prioritize, collaborate, and drive change where it matters most. So in a moment, we'll share the video introducing the RI Life Index and the 2025 results. So for more information, I also invite you to read the one-pager that was included in your handout when you came today about the initiative, and to visit our website at the rilifeindex.org. That'll get you there as well. So on behalf of Brown and the School of Public Health, I want to thank Blue Cross and Blue Shield of Rhode Island for their leadership in recognizing the importance of data as a tool for change, and for their commitment to building a healthier community throughout Rhode Island. So here's the Rhode Island Life Index.
We all want a healthier Rhode Island. It sounds great, right? But what does that mean? Well, understanding how Rhode Islanders perceive their health in real, measurable ways is the first step to improving it. That's why Blue Cross and Blue Shield of Rhode Island and the Brown University School of Public Health have teamed up to create the RI Life Index, a comprehensive look at the state of our state's health as perceived by its residents. Helping lead the way is the RI Life Index Coalition, a group of community partners all working in areas highlighted in the index and dedicated to shaping and activating the index. This index is all about you, your neighbors and friends, and represents everyone from all over the Ocean State. Let's talk about what you're looking at when you view the index. First, it's important to understand that the index is a presentation of the results of what is known as a random digit dial, or RDD survey. The results shown represent nearly 2,000 interviews conducted randomly by phone and online in English and Spanish. Every aspect presented in the index is represented by what we call a POP score. POP, or percentage of possible, shows how close to ideal that perception of a measure is. 100 would be a perfect score. 40? Well, not so much. You can also see the data broken down into some more specific measurements. In the RDD, you can see how folks are doing in core cities versus non-core areas. Core cities are the 4 places in Rhode Island with the greatest percentage of children living in poverty. The index breaks data down further by race and ethnicity, Latino/Latina, Black and white, and age, over and under 55 years old. You can drill down to a more granular level by clicking the dark blue area under the core measures. Here, you can see every specific question asked and their results. Additionally, variables tended to affect the outcome of certain RDD pop scores, and you can see these in this area as well, some better and some worse. You can also view trends for all of the years that a given measure has been in the index. Just click on these buttons to see the trends.
I'm Dr. Melissa Clark, Professor of Health Services Policy and Practice and the Director of the Survey, Qualitative, and Applied Data Research Core at the Brown University School of Public Health. I'm also the scientific lead for the RI Life Index. Here are highlights from the 2025 Random Digit Dial, or RDD, survey. This year's overall RI Life Index score is 57, consistent with 2024. The score reflects perceptions across key building blocks of health, including affordable housing, cost of living, access to nutritious food, job opportunities, healthcare access, and programs and services for children and older adults. Across groups, scores ranged from 48 to 63 out of 100. Across most measures, perceptions remained steady from 2024 to 2025, but that stability still points to ongoing challenges. Cost of living remains the lowest score in the index and continues to be a top concern. Healthcare access declined by 3 points compared to last year, with larger drops in core cities and among Black and Latino residents. Community life also declined in core cities and for Latino and Latina residents. Food security held steady overall, but meaningful gaps remain between core and non-core areas, and perceptions of economic situation declined compared to recent years. For the first time, we asked Rhode Islanders about climate change. 62% said it is a somewhat or very serious issue in their community. Together, these findings help clarify where challenges remain, where disparities persist, and where focused attention is still needed.
The RI Life Index has always sought to amplify Rhode Island's voices to ultimately strengthen our neighborhoods. In 2024, the index launched Rhode Island Voices, a new targeted panel survey initiative examining specific community indicators. This method collects data repeatedly from the same group of people. Respondents from this year's RI Life Index RDD could opt in to answer in-depth questions on health drivers. The index is also partnering with community-based organizations to include participants from every city and town in Rhode Island. Through Rhode Island Voices, the goal is to identify urgent needs, develop solutions, and drive positive change in community health and well-being statewide. Since its start, more than 5 surveys have been fielded, providing access to timely insights into how Rhode Islanders are thinking about specific issues ranging from housing, food security, neighborhood life, and more. Rhode Island Voices is a complement to the RI Life Index. It strengthens it. Together, the two tools deepen our understanding of both long-term trends and emerging concerns. And, more importantly, they enable hearing directly from Rhode Islanders in more ways. As we look ahead, the combination of these voices and data sources gives us reason for optimism. The more perspectives we gather, the better equipped we are to identify opportunities, support communities, and build a healthier, more equitable Rhode Island. So that's the RI Life Index in a nutshell. We hope, as you read the index, you get a real understanding of how Rhode Islanders perceive their health and the health of their community. But data is really only the first step. We use the findings from the RI Life Index to inform our work in addressing the health needs of our state. And we hope that you use the index as a tool to support your programs, ideas, and all that you do to improve the health and well-being of Rhode Islanders. To read the full index and for more information, visit rilifeindex.org.
If everybody could please join us for the final panel, and what'll be the best panel, I think, even though we have a lot of competition. My name is Elizabeth Burke-Bryant, and I'm a professor of the practice of health services, policy, and practice at Brown School of Public Health, where I'm based at the Hassenfeld Child Health Innovation Institute. I am really excited about this panel today, which the topic is on all of our minds, both here and around the rest of the country. How should Rhode Island navigate the impending Medicaid cuts that are contained in H.R. 1. I am delighted to introduce our panelists. Senator Lou DePalma, right here, is the chair of the Senate Committee on Finance in the Rhode Island Senate. He has been a longtime leader in health policy and recently provided key leadership for passage of a new law requiring a biennial Medicaid rate review. He has been a member of the Senate since 2008. We're glad to have you with us, Senator. On my right is Kristen Souza. She is Medicaid Program Director for the state of Rhode Island, Executive Office of Health and Human Services. She was previously Deputy Medicaid Program Director, and before that, Director of Managed Care. She has a long career in this whole world of Medicaid, and we are so happy to have you with us as well. Wayona Nelson Davies is third in the row, and she is Executive Director of the Economic Progress Institute, which is a position she has just hit the 4-year mark on, Wayona. The Economic Progress Institute is a nonpartisan policy and research organization that is dedicated to improving the economic well-being of low and modest income Rhode Islanders with a focus on racial and economic justice. It's great to have you with us as well. And finally, we have Hayden Rook Lee. He's Senior Fellow in Health Services, Policy and Practice, based at Caper. And so he is also based at the Brown University School of Public Health. Hayden brings to Caper terrific experience working on Capitol Hill in a number of positions. And what he's been doing lately is really diving into H.R. 1 and really seeing what the implications are for both Rhode Island and states across the country. So what I'd like to do is start a few framing remarks for our discussion today. I really want to note that Rhode Island has long been a leader for the percentage of its people with health insurance coverage, currently ranked 5th best in the country by KFF, Kaiser Family Foundation. And according to the Commonwealth Fund's annual ranking of state health systems, Rhode Island is ranked 4th in the nation. We know that based on my prior work at Rhode Island Kids Count, Paige Parks, the executive director of Kids Count, is here. Children's health insurance coverage has been a major priority of our state for decades. And we know it's not just the percentage of kids covered, it's the quality of health care. And Rhode Island's Medicaid managed care plans have consistently achieved high ratings from NCQA, the National Committee for Quality Assurance. So as we as a state navigate how to respond to the major changes coming in the form of Medicaid cuts in H.R. 1, we do have a lot to be proud of and hopefully a shared commitment to keep our high-quality system in place to weather this storm. The last thing I'm going to do, I often go to conferences, and I think that a lot of people, this is to level set on numbers, a lot of people hear about Medicaid, how big it is, but don't really have kind of like an index of key facts. So I'm going to give a few, and it will save our panel from having to sort of dive in and level set that way. So right now, there are, and this was updated during a walk down the hall with Kristen Souza, 298,000 children and adults are enrolled in Rhode Island Medicaid. In Rhode Island, and just listen to each of these percentages, Rhode Island Medicaid covers 43% of births, 37% of its children, 51% of working age adults with disabilities, 20% of adults 19 to 64, and 54% of nursing home residents. And this is a number, all of these numbers of course are changing, but one last one that I think is important to say is that in Rhode Island, as of this KFF fact sheet on Rhode Island, and the numbers do change, but as of this recent fact sheet from KFF, over 70% of adults receiving Medicaid are working either full-time or part-time. And lastly, how big is the budget? Financing for Medicaid, as you know, is shared by states and the federal government. Currently, Rhode Island receives $2.3 billion in federal Medicaid funding, which is about 2/3 of total Medicaid spending in Rhode Island. So I think that paints the picture of what we're really talking about some of the key facts about the program, and now we will dive in. Director Souza, let's start with you. You and your team have been working hard to prepare for the program changes and cuts to Medicaid that are in H.R. 1. We are less than 11 months from work requirements called community engagement requirements in the bill going into effect, and new redetermination requirements and restrictions on Medicaid eligibility for non-citizens going into effect later this year. And to throw all that together, some new every 6 month redetermination for the Medicaid expansion population. So I'd like to start out by asking you, what are you doing with your team to prepare for some of these changes?
Thank you for having me today. So I think it's going to be important to first just give you some context of the population that is impacted by the requirements that you just mentioned.
Mm-hmm.
So a tremendous amount of the requirements impact what we call the expansion population. So that is adults aged 19 to 64 who do not have children. And so the community engagement or the work requirements impact them. The every 6 months eligibility determination impacts them directly. And then the non-citizen changes impact anyone. So it's an important distinction to make that not all the provisions impact the entire population. I'm going to start with the non-citizen eligibility change. That eligibility change goes into effect on October 1st of this year. And currently, we estimate between 7,000 and 9,000 current beneficiaries will be impacted by this change. The reason I am putting an asterisk on that number is we're still trying to validate some of the federal information on verification for these individuals. So that number could go down. I do not believe it will go up. So that's a positive. The individuals who don't fall in this category, who will remain eligible, are U.S. citizens, lawful permanent residents after their 5-year permanent residence in the United States, Cuban and Haitian entrants, and COGA migrants. So those individuals will remain eligible so long as they meet the criteria. Eligibility will change for refugees, asylees, parolees, or survivors of trafficking, and will end, as I said, on October 1st of 2026. Those individuals will no longer have access to Medicaid benefits beginning in the fall. So right now, the work around that particular provision is really to ensure that we are able to validate each one of the individuals and keep as many of the individuals that qualify within the law in Medicaid. So that is work that is happening today alongside our federal partners to ensure that we have the right information, the proper information on each individual, and that we're not terminating anyone who should not be terminated. The work requirements or community engagement requirements and the eligibility determinations every 6 months is exclusively for that expansion population, so that 19 to 64. There are approximately 84,000 individuals currently in Rhode Island enrolled in Medicaid that fall under that expansion category. So effective January 1st of 2027, all of those individuals, and I'm going to put all in quotations because there are exemptions for this, are subject to these provisions. So everyone will be subject to a 6-month redetermination for their eligibility. And that is pretty straightforward. They'll go through the same process they go through today. Instead of doing it once a year, they'll do it twice a year. And Passive renewals, and for those who don't know what that is, that's if their paperwork and is all in line and we're able to validate their information through our hubs, so our connections to federal information and state information, they will not have to do anything. They'll be automatically re-upped. If something can't be validated through those mechanisms, then they would have to take an action. So our passive renewal rates are fairly high in the state, so that's a positive for an every 6-month renewal, and hopefully it remains that way. So I'm saving community engagement for last because it's the most complicated, and it will have an impact. So again, the every 6 months, I want to make sure folks understand that when we do eligibility determinations, there's a shorter gap than a 6-month, right? So the process really begins 60 days prior to the date of redetermination. So information goes out to a member to validate or to say, you need to provide additional information. There are notice requirements, et cetera. So really, there's a 4-month period when you think about it from a purely administrative standpoint. They still get those 60 days covered, but their action time frame is prior to a potential termination. So it's important to know that, especially for community partners, our MCOs, et cetera, so that they're actively working with beneficiaries to make sure if they need to take an action that they're taking it. There are exceptions to community engagement, and they are at the state's discretion. So what that means is to be determined, because the federal government has not given us clear direction on that or guidance. But individuals who are pregnant, are deemed medically frail, are the primary caregiver of young children under age 14, a veteran with total disability, students, Native Americans, and there are exceptions for hardship scenarios, again, at the discretion of the state. So in that instance, there'll be a determination, and those individuals may be exempt from having to participate in work requirements. We anticipate currently that about 24,000 individuals are likely to lose Medicaid coverage as a result of work requirements. It's a hard number to think about. It's 24,000 individuals that potentially will go uninsured, right? So that great uninsured rate that we just heard about is probably going to change, and in some cases it's simply because they don't work enough hours, or they're not able to work enough hours, or whatever the case may be. So right now, the Medicaid team is trying to build the systems to come into compliance with the federal government. That is an effort that is a partnership not just with the Medicaid office, but also with the Department of Human Services, who is the delegated agency for eligibility, and our partners at HSRI, who answer the phones and do a lot of processing and question answering for the population. That work is well underway. As I mentioned, the federal guidance is not out yet. They anticipate for community engagement that guidance will come in June, which is not ideal when you're trying to build a technology system. As everyone knows, technology takes a long time to build. So we're going with our gut on a lot of this right now, and hope that we guess correctly on what the requirements will be. Our federal partners have released what they call preliminary guidance, but it is subject to change. So we're obviously using that to make that build. As we move through this, and have more concrete information, we'll be reaching out to various partners. Obviously, the interagency effort is ongoing now. We will lean into our managed care organizations where about 90% of our beneficiaries are, to help us to ensure that any actions that need to happen for their members, they're helping to coordinate, providing care management if necessary, helping them to understand what actions they need to take, along with their community partners that they work with and our community partners. I would say that the largest concern that I have, there's many concerns, but the largest concern for me right now is to ensure that individuals will most likely struggle with the paperwork and understanding what the paperwork means. And I don't want to see an individual fall out of coverage for that reason. And so that's where the critical part, the critical partners in all of this, our managed care organizations, our community partners, come into play. We need to make sure that everybody is equipped with the information to help those individuals to stay covered, and also to help those who are not going to be covered anymore, and what options they then have to access care, potentially other options for insurance, or where they can get care as an uninsured individual.
Well, thank you for getting us off to a great start. And I'd like to turn to Hayden next, who has been, in his role at CAPER, really diving into HR1. Director Souza went through a lot of the provisions. I'd like it if you could raise up a few more that you've been looking into. And really kind of the question is, can you talk through the parts of HR1 that will make it harder for states to finance their Medicaid programs? And this is all to set up Senator De Palma for responding to all of that, and Wayona. So,
well, thanks, Elizabeth, and thanks everybody for joining us. Director Souza gave a, I think, quite comprehensive overview of a lot of the provisions in HR1 and the sources of coverage reductions that we're going to see. And I think the best way to understand the overall the bill is to think about the coverage losses and then the financing losses from the federal government. So if we think from the perspective of coverage losses, as Director Souza mentioned, there's really two big ones here. The projection that the state is going to lose potentially 24,000 Medicaid beneficiaries through the work requirements. What's important to understand there is that as Director Souza mentioned, the bulk of those enrollees are part of the expansion population, which is overwhelmingly financed by the federal government, 90% financed by the federal government. So if we think from the perspective of funding in the state, when enrollees are lost from the expansion population, that's a significant amount. That's $9 for every $1 the state spends coming in. Another 9,000 we expect, based on the state's projections, to be lost from the new restrictions on undocumented immigrants. And then there's going to be significant difficulties for the state to generate the same sorts of revenue that they do right now to finance their Medicaid system. This is what is known as the provider taxes. I'd add on top of that, and I won't get too far into the exchange population because I know we're talking about Medicaid here, but if we're thinking about the state's fiscal situation in general, there's an expectation that the state's going to lose another around 15,000 enrollees on the ACA marketplace due to changed rules and changed subsidies from the federal government. That's worth probably another like maybe $50–60 million coming into the state. So the picture overall here is potentially catastrophic, actually. If we think about the worst case scenario projections, particularly the 24,000 enrollees due to the work requirements, projections from the state are in 2030 that we could see overall roughly, if we add up those numbers, about 50,000 fewer enrollees into the Medicaid program, and something on the order of potentially $400 million less in the state's Medicaid system. And the way that's partitioned between the state's contribution and the federal government, again, is like, has to be emphasized here. The enrolling 35,000 fewer beneficiaries in Medicaid at the state level is going to save the state budget some money, projected about $15 million, which is quite minimal compared to the losses that are going to come from the federal government here to get up to that $350–400 million. So the bulk of that, save for about $15 million, is lost revenue into the state from the federal government. So if we think about this from the provider perspective, the state losing $350–400 million is maybe something on the order of $150 million by 2030 for the hospital system, something about 10–20% maybe of revenue for a hospital. So I just want to emphasize the point that when we lose enrollment and sources of financing in the Medicaid system, the biggest shock fiscally is going to be the loss of federal revenue. And from the perspective of the providers and their sustainability, that's something that the state, of course, is thinking about and is going to be difficult to mitigate.
Well, thank you, Hayden, for that. And we're going to play musical chairs because our broken chair is going to be replaced by something over there. If somebody could. No, you know what, people.
I'm made for a black girl with some assets.
We got one right here. Well, do you mind standing up? Because we've got TV cameras. Okay, great. Thank you.
You're welcome.
Senator DePalma is chairman of the Senate Finance Committee. What are you planning for in terms of Medicaid cuts in FY27 and the years after that? So you've been thinking about this late into the night, early in the morning. You've been hearing from a lot of people, doing prep work. What would you like to add, and how is this hitting the Senate Finance Committee?
So my first response was going to be, I'm going to hibernate for the next 2 years, and hopefully when I come out, or sleep for the next 2 years, which I can do and come out. No, we have been looking at it, and I'll talk to some of that. Just before we begin, some colleagues here, both in the Senate and the House, want to recognize Senator Urso here, Senator Gu in the back, Senator Ujafusa here, as well as Rep. Tanzi, Rep. Donovan are here. I know Rep. Potter was here before. Maybe somebody else. I do want to recognize them, but before you leave, there's a person you want to say hello to, because she'll have 40 years of questions, Dr. Marie Ganem, in the third row here. Marie, can you raise your hand? Marie, along with many things that she's done, in fact, I'll go back to somebody in a minute, was director of policy for the Senate. But she goes back to, I'm not originally from Rhode Island. I've only been here I'm in my 43rd year. She goes back to the Gary administration, a long time ago. And we also have Carly Noble here. Carly's from the Senate. Carly, raise your hand. Carly's from the Senate Policy Office, a Brown grad. Carly was an intern I had a couple of years ago, and we're glad she's now working for the Senate. So there are many people here to take notes about what's said, what's not said, whatever, but it's a big issue. It's categorically a big issue. Let me talk about what the governor's put in the budget this year as a starting point. So roughly about $20 million we'll talk about. $10 million was put in for folks who are going to lose insurance, folks that are associated with the advanced premium tax credit. There's about, I'm going to round to 10. It's 9.4, 9.5 in that number. There's also put in about $10 million for uncompensated care. For those who aren't going to get insurance, they're going to go to the hospitals and wherever and have no way to pay for it. It's a start. Is it the answer? No, it's the start. One of the challenges we have, so I've been in, as Elizabeth said earlier, got elected in 2008. I've been on Senate Finance for my 18 years, on education for 18 years, and now with Senator Gu, she chairs the AI and Artificial Intelligence and Emerging Technologies Committee. And one thing we tried to do over the last N number of years, I don't know what N is, but I think it's more than 10 years based on some of the finance chairs we worked with, is looking at the budget with an eye on the long term. It's easy to address the budget with your eye on today. Easy. It is very easy to do that. The long term is hard. The long term is hard. One thing to state, I've only seen us do this once, I think, over my time in the Senate, where we put money aside for a program that's going to not start for the next year. So we're not going to create a structural deficit because we don't have the money now, but we know we're going to start it a year from now. What do we do that with? The tangible tax. May he rest in peace, Senator Dominic Ruggiero, when he's president, and Senator Murray had the bill about eliminating a good portion of the tangible tax for businesses in Rhode Island. That cost was about $25 million. We put it in the budget for, I don't know, FY24. I'm going to make it up now. It wasn't in the FY24 budget. Wasn't going to happen until FY25. When FY25 came around, did we have to go find any money? Nope. All the money was right there. We basically had set it aside. It was a reserve, basically. So when next year came around, we had it in the budget there. But we made certain it was going to come a year later on that. So let's talk about the budget and how we're looking at it today. So I read the entire HR 1 last July, August timeframe. I read the Senate version because it was bigger font and there was a lot more pages. It was like 800-something pages. The House version was like 300-something pages, very small font, and no white space in between. One of the challenges we had that's affecting Rhode Island, affecting the entire country, $1 trillion. $1 trillion is coming out of Medicaid over 10 years. $1 trillion. We're not talking billions. We're talking $1 trillion. We're increasing the debt by $4 trillion. So make it 5 now. The debt's going to be, it's net 4, but gross it's 5. That impacts all of us. It was talked about earlier with regards to the money that's coming to the state. We didn't talk about income tax and sales tax, that those jobs that were here, that people went and spent their money on. So we're looking at things now, and I'm sure some of my colleagues in the Senate and the House won't like, I'm not going to say what I've been thinking about, what we're trying to work towards, but we got to look at this long term. We have to look at some things we're going to put in place today that will help us address this tsunami. I forgot your name again. What Hayden said, I apologize, as it relates to that 90-10 match. 90% of the federal money. So we can't just say, okay, we're going to use our own state money for it. I don't know how we generate that kind of money that we're talking about over the N number of the years and where we're going. So we are working to address this in a long-term fashion. I know we're going to talk about maybe community engagement a little bit. I got some ideas of how we can help facilitate some of that. That will grow our economy a little bit, I think. So there are some pluses here, but the other downside of HR 1, it's categorically punitive. You will not find a thing in there except for if you're at the highest income brackets, you're going to love it. Categorically, you're going to love it. If you're a business with R&D tax credits, you're going to love it. If you're from Alaska or above the 48th parallel or not one of the 48 contiguous states, and that's in there, you're going to love it. And if you want to address immigration, you're going to love it because there's a Biden account. It's actually in the bill. You can go find it. It's BIDEN, just like the Trump account is in the beginning. There's a Biden account created later on. It's actually in there, BIDEN acronym. So we need to figure out, as we move forward with this, what are we going to do both from an expense side? How do we reduce some of our expenses? How do we increase, as the governor will talk about, the jobs? How do we get more jobs? Because we have to be able to figure out this piece. One last piece I want to mention with regards to the advanced premium tax credit. So what did we hear at the federal level back right after the big shutdown of the government last year? We're going to give Director Souza the money. She can go get the insurance on her own. She'll make the decisions. We always make the right decisions ourselves. What they didn't say was the one critical thing of the Affordable Care Act, or the Patient Protection in Affordable Care Act, the official name for it, or Obamacare, I don't use Obamacare, I use Affordable Care Act, was the 10 essential health benefits. That was the core of the Affordable Care Act, categorically the core. And if Senator Miller was here, he might hug me because I said that, I think. But that was the piece of the Affordable Care Act and the expansion factor, et cetera. Yeah, we might be able to give money to Director Souza to go get insurance from somewhere, not certain what that's going to get her or give her what she needs. So we're all going to feel good that our numbers might go up, but the value of the insurance that they had before under the Affordable Care Act is not synonymous. So.
Great. We will come back on the work requirements and get some ideas from you and others. And Wayona, you've been a leader in sounding the alarm on the impact of HR 1 Medicaid cuts on people enrolled in Medicaid, including those in marginalized communities and immigrants. What are your biggest concerns in terms of the requirements of HR 1 that you believe will cause children and adults to lose coverage? And how will other parts of the healthcare system be affected? What do you and other nonprofits need to do effective outreach? For some of the people the director was mentioning, the worst thing would be an administrative error an administrative miss on paperwork that has them roll off, and then we know how expensive churn is because they roll off for something like an administrative piece of paperwork, and then everybody from the MCOs to our community partners has to chase them down the street to get them re-enrolled, and all of that costs money. So wherever you would like to begin.
Sure, thank you. And I would like to begin and set some context. Health policy is a soft spot for me. Prior to coming to EPI, I worked for 14 years as a legal aid attorney, and majority of that was really focused on access to health care. And so when the Affordable Care Act was enacted, I spent many years and months working with healthcare providers to understand what my job was and how people would be eligible and what the expansion group meant. And so I spent many years really diving into healthcare through that. And then EPI, you know, we do fiscal policy, we do a lot of policy, and healthcare policy is one of the things we work on. So I think part of my role on this panel, besides breaking flimsy chairs, is to push some buttons, right? So push. Anytime we talk about healthcare policy or I have to advocate for it, I always think to myself, why in the world does the greatest country in the world not have universal health care? That always comes to my mind when we keep talking about all these things we have to fight out. So push. I think, you know, maybe next summit we can talk about universal health care. Invite me back, because I really want to have that conversation, because the solutions get deeper and deeper and they change based on administration, and that is not the way to do health care. So I'll start there, but I digress. So back to HR 1. I have some deep concerns about HR 1. Eligibility is one thing. You can always reverse eligibility. The structural redesign of HR 1 is really what the issue is, right? Because you have our agencies now have to re-invent new systems to deal with all these requirements. It takes decades to reverse some of that, right? So besides cost, it's really a burden on the system to have to now go retrain the workers to understand the rules, retrain the public to know what to do and what not to do, and just start all over. So that's one of my biggest concerns when it comes to HR 1. 2, the vulnerable populations that will be impacted. As you rightly said, we have children, right, who may be eligible for health care, but children don't exist on their own. They're in families. They are in families who some of the parents may no longer be eligible for health care, or might be eligible and decide not to access the programs because it's too confusing and too burdensome. And what does that mean for children? It means the family economic stability is at risk, because families are going to now have to make choices between health care, food, housing, and other things they need for their families. We have people with disabilities who are also going to be impacted by this. We have seniors, right? And then we have immigrants. HR 1 intentionally targeted immigrants. And we're not talking about undocumented immigrants. We're talking about lawfully present immigrants who have been eligible historically for Medicaid, asylees, refugees, victims of domestic violence are no longer eligible for Medicaid in the United States of America. That is a targeted population that is now at risk of being sicker, now at risk of seeking uncompensated care, and that is a big deal. It is creating, what HR 1 is doing is creating a chilling effect. It's creating a chilling effect like it did under the first Trump administration with the public charge rule, where even for immigrants, like lawful permanent residents who are still eligible, might think this applied to them. Because it's like, oh my God, asylees, not eligible? I don't think I'm eligible either. And what happens, and what happened during the first Trump administration, people who are eligible stop receiving care. People who are eligible stop showing up for doctor appointments. And then you have the problem of mixed families, where children might be eligible, parents may not be eligible. You add that with the terror that ICE is putting across communities, now you have people not even wanting to seek care. So I always like to think about like the big picture of how this is going to impact real people's lives. And then the last concern I would share is obviously our entire healthcare system. Because we're talking about people, but we're talking about hospitals, right, and community health centers and behavioral health centers, where now you're going to have patients not being able to seek primary care or preventative care. So our emergency rooms are going to be overwhelmed. And that is really important, and it's going to impact our economy. It's going to impact how sicker we become. And if our neighbor is sick, we are also going to be sick. And so anytime I hear about HR1, it's going to impact every single one of us, whether you're still eligible for Medicaid or not, whether you are required for work requirements or not, it is impacting all of us. So those are some of my concerns with HR1. And then as far as what nonprofits can do, I will say this, push. Nonprofits are already overburdened. They are already dealing with their own challenges under this administration. We have federal fund freezes. We have philanthropic partners who are no longer funding the work of nonprofits, either because they don't want to or they're afraid of funding missions around equity or serving immigrants or serving LGBTQ communities, right? And so nonprofits right now are stripped of resources. And we know they're going to show up. You know, despite the fact we have less capacity, we have less resources, nonprofits are still doing their best to address what is coming out of policies like these. So I want to start there to realize that we should not rely upon our nonprofits to solve this problem, right? We need to, if we want them to partner, because again, I think all of us have to do our part, then we need to understand what it takes to provide resources to nonprofits. If we need nonprofits to help with enrollment, re-enrollment, recertification, they're gonna need capacity to do that work, right? We need nonprofits to help collect data, because again, things change. In 2 or 4 years, this might change again. We need to know who were impacted when this policy was put into place. So we're gonna need to provide the tools for nonprofits to collect that data for who's coming to them, who's seeking their understanding. There are trusted messengers. So, you know, HHS may send out notices. My mom is elder. She gets so many, notices, and I can read them. But most people are like, oh my God, I can't go through this. And they'll take it to a trusted nonprofit partner to help them navigate that. But nonprofits will need assistance, they will need investment to help with all of these if we really want to come together and work in solving some of these solutions, or some of the things we can solve. Because to Senator Palmer's point, this is a bigger long-term problem, and we can address some of the immediate needs, but we need to think universal health care, but then we also need to think about how can we really deal with all of the impact of HR1.
Well, thank you for everything that you addressed. And we will really have a boots on the ground. Who's the boots on the ground for this kind of outreach? We've been through this as a state before. We know that it costs a lot to do it well, and it's over a long period of time. So I'm going to come back to that question. So I'd like to turn to Senator DePalma, and you got into this a little bit. Two-part question. One is that I know you have some ideas for a database for the work requirements and sort of the way the work requirements language is. And then I'll go to the next one, but why don't you take that one first?
Thank you, Elizabeth. Anybody know my background is computer science. In fact, I went to Brown a long time ago for computer science, artificial intelligence specifically. But I believe this is a real opportunity. It really is. Because every state is doing it right now, or going to begin to do it, or has begun it shortly thereafter. If we're out creating our own, we should stop that immediately and take a step back. Every state's a little different with how we're going to go do this, but I think there's an opportunity to leverage, let's make it regional. I don't have to be U.S., but other states are going to have to go through and try and create the same kind of thing. The partnership with Department of Labor and Training, I haven't yet talked to Director Weldon. There's going to need to be a very, very tight connection there with regards to what jobs you got, where are they, who applies for them, because we're going to want people to have jobs, right? We want them to have health insurance. The requirement is to have a job for those who can. Just before I get there, we've all been talking about this kind of citizen or that kind of citizen. The language in the bill is qualified alien. That's what the language in the bill says. HR1 doesn't say nothing nice about anybody other than it says qualified alien. That's what they call all the people that have been here for various reasons that Leona talked about that have getting insurance that will not get it any longer. So the piece about having this database to be able to leverage is a key thing. He's not here, and the foundation's not here, but I think foundations potentially can play a help with regards to providing some assistance to WIONA and the Economic Progress Institute as it relates to volunteers, right? Because there's a few requirements. It's 80 hours per month. It's work. It's school or volunteer. Like I said, there's a lot of dark things in HR 1. I think a positive coming, I want to make this a positive coming out of it. How can we potentially help nonprofits as it relates to EPI needs these kinds of people? They look like us, they need to do this. We have some people that potentially can do that. I know it's small numbers people are going to look at, but guess what? We have to be thinking out of the box here. Anybody thinks we can't do it, that person will not have insurance. So let's figure out, I have an animal shelter in my district. Represents all of Aquidneck Island. Volunteering is part of community engagement. I don't know the specifics that are there, what CMS is going to come back with. There's some potential opportunities there. We have to be very creative with regards to how we help people facilitate this, because at the end of the day, being able to do this, keep insurance. Don't do this, the state's going to need to pay the difference of, we're going to break, the glass is going to break at some point. The weight, the sheer weight of what happens here, eligibility might change for what we do. Benefits might change. If we want to keep everything consistent, we have to be able to look and be creative and see what other states are doing as well. Nobody wants to be able to do this. Nobody should have to be able to do this. The other part about technology as it relates to, and I know the director and clearly Director Britta and DHS is looking at some of this, how to leverage some technology to help facilitate even on the SNAP. We haven't talked anything about SNAP. If Rhode Island doesn't change one thing in SNAP, we're going to pay $50 million. $50 million because our error rate's over 10%. That doesn't include the other 15, I think it is, for the additional administrative costs. Right now, it's a 50-50 match. Feds pay 50, we pay 50%. It's going to go, we pay 75, they pay 25. $15 million right off the board. And if we don't reach our numbers, we're talking in excess of $50 million a year. And right now, if they took they snapped the line right now, we're over the 10% mark. There again, if you're Alaska, you're good because they're 23% and they got 2 more years to meet the number. There again, you're not in 48 contiguous states, you're okay. So those are the kinds of things, even from a technology perspective, can help leverage and maybe facilitate making it easier for eligibility or redetermination on eligibility again, as it has to be done twice a year.
Thank you, Senator DePalma. And knowing so many people in this room, I also want to have us acknowledge that the MCOs are going to be some of the people chasing people down the street because they have a responsibility to do that, and that if someone is not, that rolls off the program, that outreach is needed. We have a number of community health workers, which is a boots on the ground, that are working in some of our agencies, and they need support. I know that Medicaid for community health workers is no longer going to flow, but maybe if you have any ideas about how to use people like community health workers to do some of this.
So I'm not sure what you mean by not flow, but community health workers are still part of the Medicaid program and certainly would be utilized as boots on the ground in this effort. Currently, we have several forums to have discussions. A lot of the struggle right now is there's still so much unknown. It's difficult to educate our community partners on what they're going to need to do because we don't have the answers yet. And so what we do have is we call it the MAC and the BAC. So the BAC is a beneficiary council. It is made up strictly of Medicaid beneficiaries who we meet with on a quarterly basis, who are helping us with what their questions are and sort of what they think they need to navigate all the changes that are coming. That work has already started. We also have a MAC, which is the Medicaid Advisory Council, which is made up of providers, hospitals, MCOs, et cetera, where these discussions are starting. But I would say they're very preliminary at this point. And until we have clearer direction on how community partners can help, I think we all know that it is to help the beneficiary navigate, but what does that really mean, and what does that look like, and what tools will be available to utilize in order to do that is still a TBD.
Well, thank you. And you have said that before, and that's so wise not to go out and train people until you know what the guidance is, and the fact that you're waiting for it for these huge things is a struggle every day, I'm sure.
Yeah, and I think we get the question every day, and the best answer I can give is most likely we'll have a much better sense coming in the summer. So that's really, I think, when you'll see a much larger boots on the ground communication effort come out of Medicaid to really engage with real concrete steps on what we need to do. And that's probably the timing at this point, so long as the federal government sticks to the final guidance coming out in June. In short order from that final guidance, that's when I think you'll start to see us really communicate more deliberately with everyone on what our ask is.
And I know there's people here from Rhode Island Parent Information Network, another sort of boots on the ground group, and everybody will be waiting to jump in.
I would just add that that does not mean that independent conversations aren't occurring.
Yes.
So obviously we meet with our managed care organizations on a monthly basis. We had one of those meetings this morning. We went through HR 1 with them. What's happening, what they can expect, when they can expect it, what we know today. Those sort of consistent meetings and conversations are happening. It's not that we're not sharing information, it's that there's not concrete information to sort of begin education and actual action at this point.
I was going to ask you a quick follow-up about the anticipated impact of HR 1 on specific populations like children with special needs or those with disabilities. Do you want to address that specifically, or would you say that's the same thing of kind of waiting to see, or what are you thinking about those special populations right now?
So directly, I would say children are probably the most protected in this change that is coming. I would agree with Winona that although children may remain eligible, their families may not. And that really is where the problem comes in. That's really the worry. I think overall, children will remain insured. However, the impact that families will have on that insurance is really where the concern comes in. There's a tremendous amount of support, and I'd probably toss it to Senator DePalma on this, but around our Cover All Kids program and maintaining that long term. Obviously, there's an expense associated with that, and the legislature will have to address that longer term, but both the governor's office and the legislature have been large proponents of that program. So I would anticipate some support for that to continue. So that addresses sort of children that are non-covered from a federal perspective. The non-citizen population, we're trying to nail down exactly how many children fall in that category, if any. They would remain in Cover All Kids. Mm-hmm. So, however, there's a potential that those families and the impact to them impact that. So it's really more a family question for me than it is about a specific child. Children will remain covered. What happens to the family and then the coverage is really the question.
Thank you. I think I'd like to go back to Hayden and then Senator DePalma on the issue of ideas for the strategic uses of, unfortunately, that number that you said this is a shocking number that we don't want to, even think about, but we have to, the 24,000. The state match for those individuals who roll off. There must be some strategic ideas about how to most strategically use that money that is no longer state match for the individuals that roll off. Do you want to start us off, Hayden, then we'll go to Senator DePalma?
Yeah, sure. Couple thoughts. One big goal for the state, somewhat obvious, but is worth emphasizing, is moving as much money as possible in the state's healthcare system and potentially from outside of the healthcare system to Medicaid. I'll emphasize again that the matching structure of Medicaid isn't going away. For every dollar that the state can spend on the Medicaid program, it can draw down federal funding at various matching rates, sometimes 3 to 1, sometimes as much as $9 for every dollar spent. So any resources that the state currently has or will save in its budget or can generate to mitigate disenrollment is crucial. So the first place you'd probably go is try to mitigate disenrollment from the expansion population through the initiatives that have all been discussed here. There's some wiggle room in the joints here to mitigate enrollment through these initiatives. So any resources that can be found to do that. Increasing Medicaid rates to providers. Again, if we're thinking about this from a fiscal perspective, the state is now capped essentially certainly for hospitals in terms of how much it can pay providers. It's capped at the Medicare rate, but if the state has resources, it will want to go as high up to that Medicare rate as possible, again, because every dollar that's spent is going to bring in matching dollars from the federal government. And then any extra resources to minimize the amount of disenrollment might go towards subsidizing insurance for folks on the ACA individual market, or potentially if the state wanted to think about creating some sort of public option that might be even cheaper, could be a place to finance enrollment for folks who are ineligible for Medicaid. Couple other thoughts here. So the state's going to be thinking about how to save money. One place to look is potentially the managed care system. Right now, Rhode Island has followed a similar trajectory as many states over the last few decades. Medicaid wasn't always this way, but really over the last 3 or 4 decades, states have moved towards privatizing their Medicaid systems. As was mentioned here, the vast majority of enrollees in the state's Medicaid program are done through private insurance companies. The evidence on this is at best mixed in terms of whether it generates savings for the state. Oftentimes, like other social programs we've seen privatized, Medicare similarly, oftentimes it actually costs the state government more to use these private insurers to administer the program. So now might be a good time for the state to examine whether that arrangement is most efficient for the state. And in particular, you're seeing a number of states in the last few years carve out their prescription drug program and generate a significant amount of savings. West Virginia, for example. So this means that the state would actually consolidate the prescription drug benefit to the state, not outsource it to MCOs, and could potentially use more of its sort of buying power at the state level. And particularly, this gets wonky very quickly, but the states are able to basically target rebates more precisely when they control this at the state level, rather than, again, having their MCOs deliver the prescription drug benefit. So we've seen a number of states, actually red and blue, carve out or insource their drug benefit and save. I was looking earlier. West Virginia saved an estimated $50 million with a similar population in Medicaid by doing that. So that's one place to look for potential savings, is ensuring that the state is getting a good is using its resources in Medicaid with the MCOs responsibly. Another place to look is on the revenue side. Some states are thinking about generating more revenue. For example, some sort of a tax on employers that might not be providing health insurance to their employees and relying a lot on the Medicaid system. So there's some states are thinking about potentially generating some sort of levy there to, again, generate financing for Medicaid, which will draw down significantly more funding. Again, making the same point that if you spend $1 in Medicaid, you're going to generate more into the state. And then the last thing I'll mention is somewhat outside of the Medicaid system, but Rhode Island is well known for having its affordability standards. So essentially, for the last, I want to say, decade, Rhode Island, in quite pioneering fashion, has limited the growth of prices for its hospitals. And as the state enters into a period of real scarcity because they're going to lose so much financing, this might also be a time to examine and potentially update the affordability standards. Right now, they're designed in a way that caps the rate of growth of prices for all hospitals, which affects disproportionately those that have lower margins and has been potentially a contributing factor to some of the distress we've seen from some of the hospitals in the state. So we could imagine updating the design of the affordability standards to more precisely cap prices for the hospitals that receive higher commercial rates right now, and alleviate the distress on the hospitals that have lower margins and have lower commercial rates there. So potentially updating that program again, because the state just has to be really precise about how we're targeting and how we're managing resources in the system. So if those savings can come from the hospitals that have better margins and have higher prices right now, and can put less pressure on the lower margin hospitals, that's a way again to try to ease the burden on some of the providers that may be feeling it the worst when the Medicaid cuts come.
So Elizabeth, thanks, and Hayden, well done with regards to, I say this respectfully, the smorgasbord of a buffet of items that we need to be looking at, we should be looking at. So I do want to say I will be walking out of here at 2:25. You may have some questions for me. The reason I'm walking out, I'm going to the State House I was invited to speak on behalf of the Senate President for the signing of the bill to hopefully keeps Roger Williams and Fatima in Rhode Island. That's at 2:45. They in fact moved it because I said I couldn't get there for 2:30. Can't be there late at 2:45 because somebody else on the other end's got to go somewhere by 3:15. So I will be walking out at that point. So a couple comments on, I'm glad Hayden did what he did. It was a good prelude to some of this. You heard earlier with regards to the General Assembly, what we passed several years ago was requiring the state to do a formal, regular rate review on health and human service rates, Medicaid, health and human service rates. That was done. We gave the work to Commissioner King, who was over there, maybe sitting over here before. He did a phenomenal job at it. That's up for renewal in the budget this time because it's already been in place for 2 years, which is great. We've been working on this for a long time to try and get there. We're one of a few states that doesn't do it. We're doing it now. To the point where the governor in the budget said, oh, we're going to do 50% this year and figure out 50% next year. So you heard me say before, what does that do? We're already assigning a structural deficit to next year if we say we're going to, and there again, the General Assembly passes the budget, right? So we're saying, by doing that, we're agreeing that that's, quote unquote, technically agreeing that's going to happen. What's underway right now, and what Commissioner King is doing is a formal, regular rate review on the other piece. We specifically, we were very intentional, didn't want to do this. We separated the healthcare side of things. That's going on right now. Why did it take so long for Charter Care and, for Roger Williams and Fatima to be taken over by somebody? Somebody said, well, and I love Brown University Health. They do great work. Somebody said, well, they bought the 2 hospitals in Mass from Stewart. Why didn't they just buy the ones in Rhode Island? The reimbursement rate was abysmal. Why would you buy it? It wasn't meeting what it needs to go. Reimbursement rates higher in Mass, both Medicaid and Medicare. So at the end of the day, and oh, by the way, the state threw a whole bunch of money at the hospital. We don't have a whole bunch of money to throw at the hospital. What we're doing is basically a backstop, basically a credit reserve that hopefully at a point in time, we're going to get all of our $18 million back. We will get all the interest over time, but put that aside for a second. The challenge we have, and I've been trying to think about this and work on this, is all those things that Hayden just talked about. Any of those in the budget? No. Did Director Souza do some of that work? Yes, she did. In last year's budget, during, we'll call it reconciliation, one of the things we put in was we wanted to ensure that we would have a report from SNAP by October 1st. Director Brito and her team gave us a report by October 1st. We had a session with the Senate President. We also briefed this to the full Senate in January about this is what the impact is, and these are some of the things we can do. They did a sensitivity analysis of some abuse cases to figure out where it goes. Director Souza did a similar thing with Medicaid. We also had Director Lang do that same thing. That was due October 31st. We have that. We had that review in mid-November with the Senate President or whatever. We need to figure out how to pull the thread on all those things. None of it's in the budget. But we have to start acting today. Acting today. I want to get back to one piece in a minute. We talked earlier, for those not familiar with Cover All Kids. Cover All Kids is providing health insurance for children that are not citizens here. And we have, was it 5,000 or 8,000 now? Okay, about 7,000. We originally budgeted, from fiscal notes that we had, 1.5, the max was going to be $1.5 million for this. Today, $16.5 million in the current year's budget, I believe, or next year's budget. 16.5. And those children need the health insurance. So we talk about approach like a Cover All Kids kind of thing. Multiply that for adults that may have other kinds of conditions or whatever. That's a lot of money. As Hayden said, one of the things we need to figure out how we can be very creative on, and we're going to look to Director Souza for, is look into your CMS book and go to page number 7, paragraph 3. Let's try that one. By the way, we did some of this with regards to 2 years ago. We were only the second state that put in the Medicaid code 0330 or whatever. Oral dental health, surgical or oral dental health or whatever, I think, or whatever it's called, ambulatory dental health for kids. Guess what? We never had it before. We now have it. We're now being able to address oral health for children. We also did it for chiropractic. Why? And Dr. Gannon will remember. It showed that it had a direct impact on less healthcare costs after the fact and less impact on folks that might become addicted to some kind of pain medication. Those are just some of the things, but we have to be able to look into that Medicaid playbook, figure out what other states are doing to figure out how to address this. There's no easy answer to this, and we have to start today. The majority of the impacts from the budget, from a state budget perspective, happen next year. Some begin sooner than later, like the eligibility returns, the SNAP stuff will start October 1st, I think. They're figuring out those numbers now. It's going to happen October 1st. And if they pull the trigger today, let's start writing that check for $50 million. Beyond that, we have a little bit of runway, not a lot. We really need a concerted effort that says, it's almost like a think tank group having to come together, which I've been thinking about, figuring how do we address this, to go look at many of the things that Hayden talked about and do that analysis, throw all the stuff at the wall, and understand and appreciate the impact of it, the timeline of it, and how it then affects, what does it cost, what's the cost of implementation, because that's an impact as well. But every state is impacted by this. There's some red states, or some, I don't think there's many blue states that didn't go to the expansion group for Medicaid, but there's many states that are in the same category we are. We almost need to have some kind of a, I would say international. Maybe we can go to Greenland and bring Canada in and have an international conference with our 51st and 52nd state to figure out how to address some of these, but it has to happen today.
Well, thank you, Senator Palmer, and I know you have 6 minutes. So I would like to turn it over to Wayona. We're sort of talking about a perfect storm of the Medicaid cuts and the SNAP cuts. What are you thinking about that? Where should Rhode Island go?
Right. And I will say, like, the healthcare world for the last decade or 2 decades have been talking about healthcare through the lens of social determinants of health, right? Because we understood that when we talk about healthcare, it's not just walking in a doctor's office, getting treatment and leaving, right? The healthcare system requires you to look at everything that impacts that patient, so the whole patient. So we're talking about whole people here as well, that will not just have Medicaid cuts. The same families that are dealing with Medicaid cuts are also going to be dealing with SNAP cuts. They're also going to be dealing with increased housing and utility costs. And so they're looking at their budget. They're looking at their monthly budget and really figuring out, can we afford cost of living anymore? That's the perfect storm. You know, we are looking at policy, but families are looking at how is this impacting whether we can feed ourselves, take my child to the doctor, or keep our electricity going. And so that is really what we need to, when we think about a solution, I think about integrated system, like the social determinants of health. And I will say this, you know, when I talk to other national states organizations, Rhode Island have been, over the years, building our systems to talk to each other more, right? And so part of the issue with the SNAP or the Medicaid is now all these reporting requirements. And the work requirements, and I have to address this, is not because people are not working. You have people who are actually working, volunteering, that do not apply because they don't want to have to deal with the reporting or don't understand the reporting. So we actually have eligible people who are already abiding by the work requirement. So that is just a deterrent for people not to have access to benefits. So I'm thinking about when we think of perfect storm, should we spend more time investing in how all of our systems can talk even better to each other? If I do an income eligibility process for SNAP, automatically go to Medicaid, and I know we've been doing some of that, but how can we make it so communities understand I can go to one portal and you can figure out whether you're eligible for that? So I'm, as we're thinking of solutions, I'm thinking about how can we work better together, and not just the agencies, because our agencies are overwhelmed. Have patience with them, people, because I've worked with, Medicaid, I've worked with DHS, and there's a lot they have to understand themselves. And so really thinking together, how can we make it easier for them, make it easier for the workers there to understand all of these many rules, and then how can we make it easy for community to have access? And then the other part of the perfect storm, and you brought up the how do we spend our limited resources? Health equity is an important piece of this as well. So we must do an equity analysis to determine if we do have limited resources, who are the impacted populations we need to prioritize? So the children, right? The people with disability, the immigrants who have no other way where to turn, communities of color who have been dealing with health disparities. So sort of, again, doing in-depth, taking this time before we start spending money, before we start creating policies upon policies, let's make sure we're not harming more communities again. And then obviously, I won't be me and I won't represent EPI. We need to raise money. We have a lot coming and talking about long-term planning. Even Rhode Island, we've made some policy choices that have impacted how much revenue we have to spend to deal with crises like these. 20 years ago, we changed our tax structure. And we've had analysis. We have a plug for a new EPR report talking about in the last 20 years, calculating this tax year, we've lost $590 million we would have had this year if we didn't change our tax structure. So we have to talk about that. Push, push. We have to talk about raising revenue because we need to be self-sufficient. We don't have a federal government we could depend on anymore. Rhode Island has to start thinking about how we can make sure we protect our people, protect our agencies, and do what we must to make Rhode Island a place where everyone can thrive and be healthy and have food.
Very powerful ending, all powerful presentations by our panel. Does anyone have a question they'd like to raise? Everything will be quick questions, but I want to throw it out there. Hello. Hi. Super fast.
I'm going to read this off my recent social media post.
Oh, could you please introduce yourself? That'd be great. Introduce yourself.
I'm Diana Desjardins. I sell health insurance in Rhode Island. I just put this on LinkedIn recently. Seems crazy to me that Rhode Island will impose a financial penalty on individuals that go without health insurance coverage. It's unaffordable for thousands in Rhode Island. It would be better to let the uninsured use that money for their medical care, like a visit to the pediatrician, don't you think?
Thank you. Who wants to? Okay, thank you. Oh, so this, would you like to answer that?
Yeah, I think, and I have to go back to my ACA days, I think because it's a federal requirement, I'm not sure if the states can override the penalty for, so again, HR 1 is setting people up to fail, right? But I'm not sure, so it's something to look into whether Rhode Island can do anything about that.
Okay, thank you. That will be looked into. Any other last question before we, yes.
Hello, my name's Jessica Eagles. I'm the Chief Executive Officer of the Rhode Island Free Clinic. I'm one of 2 free clinics here in Rhode Island, and we serve folks who are uninsured or cannot afford health insurance. The School of Public Health recently did help us complete an economic impact survey, and we found that every 1,500 visits that we do yields $1.2 million in savings in emergency room visits. That is a substantial amount of savings in a time of extreme crisis in healthcare. So my question, it was 2-part for the senator. Is there any appetite for the state to support nonprofits when we can be part of the solution? And my other question for you is, as a small nonprofit, what can we do to amplify our voice and show up that we're serving the community alongside the FQHCs and community health centers?
So let me apologize in the beginning. I missed the first part because I was going out the door and then I heard my name, so I came back. I can answer the second question, second part. What was the first part of your question again? I apologize.
The first part is that we yield a large amount of savings for the state in emergency room diversion for every 1,500 patients we see. And we did over 6,600 visits last year at our clinic alone. Because we're in extreme crisis in this, is there any appetite for the state to help the nonprofits be part of the solution in this time of crisis?
So I think the short answer is yes. And let's speak specifically to I'll go to food for a second, right? What we've done over the last several years, given the issue of food insecurity, amongst other things, additional money was provided to the Rhode Island Food Bank. The governor in the budget upped that number to, I think, what we had last year, maybe added a little bit more to it, I think, recognizing that need. Is it enough? I don't know. I don't think it is, but I have no way to calculate it needs to be this because. So we need to figure out what it is. So the short answer to the question is yes. I think the way you can be involved or get involved, and so I don't think Rep Tansey sits on finance. So Rep Tansey sits on Finance Committee in the House, subcommittee chair of Health and Human Services. They'll be hearing. I don't know their schedule. I don't even know mine sometimes, but I try to remember mine. We'll be planning it out for the next, once we get through the break. I encourage you to be at that hearing where it talks about those things that, whether it's the food bank thing or whatever, you could be there for that. Other kinds of things to be able to share, here's how we can help. Whether it's the case of the $10 million that's going for uncompensated care, like I said, I'm rounding it up, the $10 million going towards the advanced premium tax credit. Is that enough? I don't think so, but we'll see. Be at those hearings to say we can do more with a little bit, just like the FQHCs. The FQHCs are a phenomenal organization. I'm just going to speak from the one from my district, East Bay CAP, located there. And what do? When you walk in the door, I'll be very facetious and direct. You can go if you get your physical health, your mental health, and your oral health all in the same place. And for parts of the population that have those challenges of don't have transportation. The biggest issue folks on Medicaid that don't have transportation is they miss appointments. So guess what? Doctors don't get paid if they don't show up. Putting it all in one helps facilitate some of that. So you can go from one to the next. We need to figure out how do we do more of that across the state. So I think, I'm not saying that's thinking out of the box, but we're going to ask. And so the thing about the other part about the CAP agencies, that's phenomenal. I remember back 40-something years ago, just in Newport, there was New Visions. That was what the CAP services were for Newport. It then became CAP whatever, then became Newport County CAP, and what is it now? EBCAP, East Bay Community Action Program, to try and help reduce those costs as it relates to overhead and administrative, but still provide services that they were, or maybe even more, because they have the funding they have, maybe a little bit more, but even the same funding, less went to administrative, more was able to go for. So, not that the administrative costs haven't gone up. They clearly have if you're going to give people insurance and all that kind of stuff, which we hope they do.
Well, thank you. Thank you. We're going to follow you out, Senator. It's 2:30, and we're going to have Andy Ryan come up for a few words. Oh, sorry. Hayden sorry. Go ahead.
I don't need to.
No, go ahead. Go for it.
I was just going to add on to the question and hit on a similar theme of being sort of maximizing federal funding. FQHCs are another place to look. FQHCs draw down a different source of federal funding through grant funding through the HRSA program. So the state, if the state wants to think about expanding access in that way, then that's another way to bring down federal funding. The FQHCs also access drugs at significantly cheaper prices as a provider, so that's another way to sort of efficiently provide care. They also get enhanced Medicare rates when they see patients. So a similar theme, FQHCs are definitely a place to look if we want to maximize the amount of basically federal dollars that state investments can create.
Well, thank you so much, Hayden, and thank you to our panel, to Kristen Souza, to Iona Nelson-Davies, and thank you again, Hayden. Please join me in thanking our panel, and thank you for being such a great audience.
All right, excellent. Thanks, Liz. So it's 2:30, the day's over, sadly, although it's great to see so many of you here after a long day. And I'll say my assessment of how well this worked was not only the quality of the presentations you saw, but the conversations that people had in the hallways, the connections that we all made. So, you know, Kid Rock was supposed to show up, and maybe he went to the alternative venue, I don't know. But maybe next year. And so I just want to say thank you to Nathan Hostert, who did so much to bring this together. The CAPER staff, Becky Ebling, Rob Hancock, Juan Salazar, thank you. And then, you know, I also just, last thing I'll say is that this is not a one-time deal for CAPER. We're very interested, we're invested in the state and bringing people together. So I'm just going to say right now, it's not the Rhode Island Health Summit, it's the first annual Rhode Island Health Policy Summit. So I hope to see you all here next year when we do it again. So thank you very much.